Hi everyone. Just want to welcome you all to the first metabolic medicine chemical pathology training day on metabolic bone. I think we'll get started. We've got quite a busy day ahead. So our first speaker is Professor Andrew Wallet, who is a consultant rheumatologist, and he's going to be talking to us about DEXA scan interpretation today. And I think he's got quite an interactive talk, so keep your chat open on the right of your Zoom, and he'll be asking questions. And if you just pop them in there, pop any sort of answers and things in there. Perfect. So I'll hand over to you, Prof. Wallet.
Thank you. Great. Okay, I'll share my screen in a second. I'm just going to get this sorted. So share the screen. Right. Can you see that okay? Yep, wonderful. Okay, on one slide. So, well, wonderful to talk to you. I'm from the West Midlands, and my other role is postgraduate dean in the West Midlands. So it's lovely to be able to do a clinical talk today. Can you still see the screen okay? Is that, Matt, is that all working? Yeah, good. Okay,
Perfect.
that's fine.
Perfect.
So my specialist interest has been osteoporosis over many years, and it's good to talk to you today. I'm going to talk about what osteoporosis is, quite basic stuff, just to bring you into it. We'll talk about the pathways, about how that integrates into an osteoporosis service. In Dudley, where I work, we didn't have one until 2007 when we set one up, and how DEXA scanning fits into that. It's only part of the whole service, from identifying cases in general practice right the way through to management with some of the more complicated and expensive drugs that we now have up our sleeve. But it's a huge epidemiological problem that in terms of population need and falls and fractures that we need to be aware of. And so um, I want to bring in a number of cases, as we were just saying, that we can just invite you to sort of put your thoughts in the chat, and we'll talk through them. These are real cases I've reported on in my DEXA scanning um, capacity. So some of you may, you know, in the future be reporting. Some of you may well be seeing those the scans themselves. So it gives you an idea about the kind of thing we're seeing and the pitfalls of interpretation, which I think is important too. And then we'll talk about some of the tools that we use, such as FRAX, which is the common one. There are others as well, but I'm going to concentrate on that today, about how we can then make decisions, informed decisions about the treatments we should use. So that's really the essence of today's talk. So osteoporosis is a dynamic thing that happens to bones, and bone is obviously turning over continually. As you know, normal bone is with cortical bone is a very dense three-dimensional structure. With osteoporosis, the number of those three-dimensional links become thinner. They become more fragile and fewer of them. And of course, people can walk around with osteoporosis, and of course not know about it because it's asymptomatic. But of course, here you've got a small area of bone on the right here, which has had a small microfracture. And as these accumulate, of course, the structure becomes more fragile, and it doesn't take much for it to crunch down or to fracture completely at the neck of femur, with inevitable consequences. And as you know, fracture neck of femur, often the people who suffer these often go down one notch of dependency. So if they've been independent, they often then need extra care. If they're already having care, residential care, they can end up in a nursing home. And of course, it's got an 18% mortality. So those already in nursing home, or those with lots of other multimorbidities, can be one of those things which can be ultimately lead to the loss of life. So it's a huge epidemiological problem. So osteoporosis is around low bone strength and that increased risk of fracture, with all those factors, it's social factors that come into it afterwards. As you probably know, that the bone is a dynamic structure, and the balance between the osteoclastic activity absorbing the bone and the osteoblastic activity in remodeling that should be in perfect balance. And that is the case in our young, healthy population, so that the status quo remains the same, although the turnover is there. And of course, you'll get a little bit more on turnover markers and bone markers later on, which I'm not going to cover in detail today. But this is really a longitudinal look at life, if you like, and the population will reach peak bone mass around 35, and it's all downhill from there. And after obviously the menopause, the accelerated bone mass, bone loss in women will be more marked. There is this arbitrary red line across showing a fracture threshold where someone is at risk, and of course our female population will cross that line of risk quicker than a man would, because the peak bone mass is less. But also we need to concentrate and think about this early stage of life, the need for proper nutrition, vitamin D, and all those things that one should have to make sure that you reach a good peak bone mass and bank enough bone for later life. There are lots of factors that play part in that. We'll talk about genetics. We'll talk about some of the risk factors that can cause an increased acceleration of bone loss as we're going through life. That doesn't necessarily mean just in the elderly, but in youngsters as well. So talking about how, if for example, you were asked to set up a care pathway for osteoporosis, how would everything fit together? A lot of it, and when I'm going out talking to my primary care colleagues, is about identifying those people in practices, or perhaps in a respiratory clinic, or in your own practice that may be at risk. Rheumatoid arthritis is a risk factor, for example. So my colleagues that do a lot more general rheumatology than me would send me quite a few patients. So identifying those patients through various systems is important. And that could be people turning up to emergency departments with fractured femurs, and hoping the orthopedic surgeons then refer you on later on, or perhaps there's an orthogeriatric assessment or fracture liaison service that can provide that. But people even fracturing a forearm later in life, the increased risk of future fracture, secondary fracture later on, is hugely increased. So ladies in their 50s and 60s with a fractured forearm, one does need to look at their fracture risk and decide whether we need to go on and have a closer look to see if prevention is important. And of course, the medical training review and 10-year plan and all these things. The 10-year plan, one of the things about it is moving from cure to prevention. So this is really important at the moment. So we'll talk about DEXA scans and in a second, and about FRAX in a bit more detail. But a lot of what I do in osteoporosis clinics is investigating the underlying cause of osteoporosis, not only the treatment of it and providing those more sophisticated drugs that we have now, but often it's very much general medicine. It absolutely, you go into a clinic, I get exposed to all aspects of general medicine because of the risk factor that we need to delve into to try and find out what's going on. Apart from the fact that my perhaps more elderly population, which make up the vast majority of our clinics, have accumulation of multi-morbidities, which require that global general medical sort of feel to looking after them. So it's general medicine osteoporosis clinics. So I'll just put that little thing out there for those of you that are looking after patients to consider all of those other aspects. And then of course, some patients do end up on treatments, and it's about monitoring those and with appropriate use of DEXA scans and bone markers if that's important, and to manage them clinically. So DEXA fits into this, with another pathway which is described by the Royal Osteoporosis Society, and it just talks about the logistics of this, setting up local criteria for doing those, justification by our radiographers, because it is a form of ionizing radiation, albeit very small radiation dose of DEXA scan, but we do have to be aware of that and those regulations, and all of us doing DEXA reporting have to do the relevant training to make sure that we have the IRMA standard for making sure that we're doing the right thing in terms of ionizing radiation. Then the visit itself and the reporting is quite different. The reporting, I think, in different units. Some of you will come across quite detailed reports with clinical interpretation, which is similar to what we do. Others will just be a DEXA scan with figures, and that can be sometimes difficult to put things together without context. What we also do, and I think most units would do now, is also have a patient questionnaire that the patients will fill out when they come for the DEXA scan, and that's very helpful. It's surprising, actually. Sometimes it reveals stuff that's not on the referral, and you put those together, and that can help us to give it a clinical interpretation to the facts, the figures that come out of the DEXA report, DEXA out of the machine itself. Okay, so just talking a bit about DEXA, it is a strong. It's the only one. It's a strong predictor of risk of fracture, not infallible. It looks at the bone mass, not the quality of the bone, which is an entirely separate thing. It just gives you a feel for the bulk of the bone that's there, but it has that importance in determining our management. There are pitfalls in DEXA scanning, and of those of you with a particular interest and want to develop that in your career, there are some excellent courses, and the Royal Osteoporosis Society run a DEXA interpretation course that goes through some of those things. And our radiographers are usually pretty hot on getting things right, such as positioning of the patient, making sure the spine is absolutely straight, because if it's curved, and it can be very difficult. Patients with kyphoscoliosis or who have difficulty getting up and down off the DEXA scanning table, it can be difficult to get them in just that right position. And often the radiographer will put a note on the scan to say, it was difficult to position this patient. And when I'm then interpreting it, I have to be aware of that and make a comment about that if that's a problem. And that's a standard that we should be adhering to when we're doing reporting. So balancing the amount of soft tissue either side of the vertebra is important, making sure obviously you're labeling things correctly. Artifacts can be an issue as well that can surprise you. So watch out for those too. I've got a case later on that might demonstrate that. When we're looking at the hips, obviously the position of and the rotation of the femur needs to be absolutely right, because again, it can lead you up the garden path if you've got it wrong. And again, our radiographers should be able to sort that out or comment if it's a problem. So those are some of the issues with positioning we need to be aware of. So what do we see when we see a DEXA scan report? By the way, throw anything in the chat if you want any clarification. Pop something in the chat and I'll explain as we go along. There's quite a few people, but I'm quite happy to bring that in if you need me to talk about it. So this is what we get of a scan. The normal areas we see, of course, are the spine and the hips. So I've taken this off a patient with a normal DEXA scan. So we have the normal bone density is done in standard deviations. So +1 and -1 standard deviation either side of the mean is defined as normal bone density. So you can see this is what we call the T-score. So down to -1 to +1 is then the green area for a healthy young patient, age 20 or 25. That's how it's standardized. So and then we see various standard deviations going below the mean that give you what the T-score represents. The lines that sort of slip down like this are age matched. So a bone density in the middle here of 0 when you're 40 would be normal for age, but as you go into your 90s, for example, the T-score of -2 is in the normal range for someone of that age. Obviously, that's why they're more increased risk of fracture. But what we can do, it can be important to look at those, because if someone's got low bone density for their age, one would then start to look for secondary causes for osteoporosis that might be relevant. We'll talk about that in some of the cases. So this is a patient bang in the middle of the normal range for someone of that age. Yes, they've got a borderline at about -1 in terms of the bone density, but that's what would be expected. And the T-scores are expressed here. So -1 here shows they're right on the bottom of the normal range, if you like. But with a Z-score of 0, they're bang in the middle where they should be for that age. So for the hips, again, it's a similar story. They are actually, here we are. They got the values here are T-scores of -0.1, -0.2, and that would put them in the normal range. It's because it's within one standard deviation of the mean. So hopefully that's pretty straightforward, but important to keep in mind when we're going through some of the cases where it deviates from this. And so I shall move on to talking a little bit about some of the, oh, it's slipped, some of the aspects of what we're looking at in more detail. One thing I need just to mention to you is looking at vertebral deformities. It can be quite difficult when you look at a plain film of plain X-ray, or we'll go on to talking about vertebral fracture assessment in a moment, which is an image we can create on the computer when we're doing a DEXA scan. But basically, we can grade vertebral deformities according to the appearance. The VFA, or the vertebral fracture assessment, or LVA, lateral vertebral assessment, is something we don't do on all patients, but it can be very helpful. I'll go on to talk about that. Patients on steroids, for example, would be a very good example of that, where we would do it more routinely, particularly because steroids can affect the lumbar vertebra, the vertebrae, more so than the hips. So we would do a lot of these, or we might, if the patients report that they've lost a couple of inches of height, we might ask the referring clinician to rebook, maybe get a plain film of the lumbar spine on the upper thoracic spine, or recommend a VFA, which is less radiation at the end of the day. But what we'd see is these vertebral deformities here. Now, obviously, the severe fracture, absolutely clear. There's a wedge-shaped fracture there of the lumbar spine. But the more subtle ones, particularly the sort of grade 1 mild fracture, can be difficult to spot. And also, when patients got a lot of degenerative changes in lumbar spine, it can be quite difficult to interpret. So I think you have to be careful, particularly with VFAs, of making with some of these more subtle ones, categorically saying this is a fracture, because that's going to influence your management and perhaps put patients on drugs they don't need to be on. And let's face it, as with polypharmacy and elderly patients accumulate tablets, we want to try and be circumspect about the tablets they're on. So you need to make it a decision based upon facts. And as I say, it can be quite difficult when you've got a mild fracture. And on a VFA, if it's a bit suspicious, we would recommend a plain film or MRI just to confirm the diagnosis. So what are the indications for VFA? I mentioned steroids. We're debating this at the moment, but women who are much older, or men, then one could say this would be a good indication. But these have been changing, these recommendations. But I would say someone who's losing a height loss of 1.5 inches or more would be a good indication that we use, or as I mentioned, steroids. Okay, I'm going to move on because I want to make sure we cover some of these clinical cases. So this is the meat of my talk today, and hopefully this will give you a good feel. Now I put it in context of how we would manage, how I would report a DEXA scan. So this pretty much is what we've seen. This is a normal DEXA scan that we've described. So my second case I will go on to now. So have a little look at this, and I'll give you a bit of context. So it's a 73-year-old lady that's lost some height. So you can see here, there's this lady's on bisphosphonates, by the way, and we need to decide my recommendations for treatment. So have a little think, pop a few thoughts in the chat for a few seconds, and then I'll walk you through this scan and how we interpret it. So I'm waiting for the messages to come in. while you think about it, Amro's asked, are T-scores or Z-scores more useful decision-making? T-scores is the answer, the absolute risk of fracture, but Z-scores, when you get the more elderly patients, they can help us to say, well, we should be looking for secondary causes for osteoporosis. And again, I'll show you a report, which will demonstrate this very nicely. Okay, so everyone's thinking hard. So I'll just talk you through this one. So this is someone who's lost height, and as you see, it's very difficult to interpret the lumbar spine. There's a bit of a scoliosis. There's a bit of an increased bone density. It appears here. So this could be degenerative change, because quite often the lower lumbar spine, you get more of this. But they've lost, perhaps a couple of inches of height. Got to worry there might be a fracture. Okay, so and looking at this, you can see the bone density over time has been dropping quite sharply because they've had more than one scan done over time. And what we're looking for here is a drop in bone density over time. So we've got between 2013 and 2018, they've dropped quite a lot. Between 2008, that's 2-year period, they've dropped 7% of bone density here. So it's quite a big drop. And suddenly the bone density shoots up again. So this indicates that something has happened, and the most likely reason for that, let's face it, is a fracture, because the bone is crunched together. The bone density then appears to be higher, but what's happened is you've had a fracture. And I can look down this list here, and I can see normally you would see the bone density increasing as you go down on the separate lumbar vertebrae, but if one is suddenly increased, and then, for example, I can see perhaps minus 1.4, but L3 is and L4. Well, yeah, they're higher than maybe one would expect. So you think maybe the fracture's there, but at the end of the day, you probably need to get some plain films or a VFA to show that. So there's in the context of degeneration, you can't tell. So as I say, you've got to get that scan done. So if this patient is on bisphosphonates already, just with the hips, it's a gradual decline in the hip, and that's probably to be expected. It's sort of following the lines of where you would expect at age. But if this patient's already on bisphosphonates and has been on bisphosphonates for more than a year, then we can perhaps think about some of the other treatments that may be available. We call this a bisphosphonate failure, perhaps. One of the reasons for that is poor compliance. They're not very nice drugs to take or to remember to take. It can cause lots of GI upset. But there are other drugs that we could use. I'll talk about later, that we could introduce to help. Maybe it's trying to emphasize compliance of bisphosphonates, as simple as that. Maybe it's thinking about some of the drugs like denosumab or zoledronic acid, or some of the anabolic drugs that we use. I'll describe later. Anyway, anabolic, yeah, definitely. Romosozumab is another one we will discuss in a bit. Okay, good. So this is the third case. Okay. So this is a 59-year-old lady, and what you need to know is she's gained 18 kilograms in weight between the two scans. So we're comparing the scans between 22 and 25, and if you look at the weight gain, it's quite considerable over that time. So when we're interpreting the scan, there's not an awful lot of change between the two, but if people gain weight between scans, any thoughts, pop in the chat. How would that influence how you're reporting the scan? Any thoughts? I'll let everyone type for a second. Okay. Yes, but you would expect a bone density perhaps to increase. Sometimes the tissue in front of if people have gained a lot of sort of centripetal obesity, the images aren't so good either. But yeah, quite often there's an increase in weight. Having said that, we do know that sarcopenia, lack of muscle, and obesity over a long period of time does actually is actually a cause of reducing bone density. So although you think, oh yeah, you might be loading the bone more, it gets stronger, the lack of muscle, the lack of use can have the opposite effect. But to just summarize, if you've gained a considerable amount of weight, it's very difficult to compare between scans. What we're looking for between serial scans is a change of, I mean, it is statistically significant, not necessarily clinically significant, but if you see a 2.8% difference between the readings, say in the spine or the hips, between a scan 2 years apart, we would define that as a statistically significant change, and that would one we would comment on. Now, of course, the patient has to be the same weight, the same position, on the same scanner, and all of these things, because we're talking about tiny tolerances here. So there's always that bit of pinch of salt that you would provide with your report, but it can be helpful when you're looking at serial scans to see. There's no point scanning less than 2 years apart because of the variation and things of that time. You need to wait for a period of 2 years to allow a meaningful interpretation of a change. But yeah, the disclaimer is a good idea, Jessica, and I put that on the bottom of all my scans after my signature, saying weight gain can make a difference, and just interpret with caution. We had a new scanner about 3 years ago, and again, it's another rider I put on the bottom of all my DEXA reports, that just be careful anything before 2021, because comparing back before then with now is difficult, even though they try to calibrate the machine in a similar way when they set it up. It can be tricky. So if there's been a change in the scanner itself, then that needs some interpretation. Sometimes we get scans from sent to by the GP. They've had another unit, another part of the West Midlands, and I have to say, well, you've got to be very careful in making any interpretation of this change. Okay, so it's difficult to say what percentage weight change. I think it's a continuum, but I think if you've got 4 or 5 kilograms or something, I think it's going to make a change. But you can see some patients, you look at the serial scans, they're gaining weight scan after scan, or they've lost weight. So that will make a difference. Okay, I'll move on to get through all of them. So this one is number 4. So we have a 70-year-old man who has been on steroids for giant cell arteritis. And what we can see here is a very raised bone density. So you can see these T-scores are plus 0.3. So this is, it's way above, the surface of the earth. It's floating like a satellite above the all of these lines. Same with the hips as well. Is there anything you might think of here? This is a particular case that we would need to, it would ring an alarm bell. Anyone? I'll give the prize for the person who puts the blood test that I want to do in the chat. It's a good one. There's a particular blood test I want to do. Yeah, they're all coming in. They're all good ideas, but ALP is good. Yeah, any others? This is an elderly man. Someone's on the right track. Testosterone. PSA, excellent. Yeah. So osteosclerotic metastases from prostatic cancer. You've got to exclude it with a raised bone density. It's probably degenerative change. There are other. I won't go into all the other things today, but yeah. But hypoparathyroidism and other things as well, which is much rarer. But I would always get a PSA checked, and we picked up prostatic cancer just from the DEXA scan from this. Okay, sometimes patients will, they've got prostatic cancer they're on drugs to suppress, the testosterone and the rest of it for part of their treatment. PSA. Okay, let's move on. Case 5. So this is an 83-year-old lady who's had a T12 fracture, and she's got a raised bone mineral density. You can see again, this is quite high, less so in the hips, but the top, pretty good, you'd say, for someone that age. But she's had a T12 fracture. I know she's quite elderly, but is there something here that you feel is a bit peculiar? Any thoughts on that? This could easily be a patient that's a bit younger, maybe, has had a fracture, but someone with a raised, you think, well, raised bone density in a fracture, well, that's more unusual. This is a man, not a lady, sorry. correct myself. Any thoughts? Well, what I will say is I think if you've got a man that's had a vertebral fracture, maybe particularly in the sort of 50s and 60s, you do see it in the clinic, or a younger woman who's had a vertebral fracture, it is more unusual. And I would say get an MRI always. As long as there's no reason you can't have an MRI scan, because there could be an occult pathology here going on to explain that. I wouldn't accept that as just osteoporosis. Of course, if there may be a history of high trauma, RTA, when in their 30s, to explain it. But someone who's had a say a vertebral fracture of a younger age or a man, I would always say just look out for those occult things, malignancy, infection, or other things that might be going on. And if there's a signal to indicate a recent fracture on the MRI, that's helpful too. And if the only explanation is osteoporosis, they're all well and good. But I would do those things, and I would, look for other disease that may be underlying all of those malignancies that can metastasize to bone. And I picked up pancreatic cancer. It's unusual it would even get to that stage where it metastasizes, but someone with an unusual fracture, just think of those other things that might be going on. Okay, let's move on. Case 6. Ooh, it's very sensitive. So this one here, very high bone density at one vertebra, 7.3. It's just ludicrous, isn't it? That's really high. What's going on there? Any idea? This looks like an artifact, doesn't it? Yeah, absolutely. It's actually probably a pound coin or something that we didn't know. But it seems like the shape of a pound coin. But when I see that, I'd say, well, no, that's a bit odd. The radiographer would normally pick it up. I think they just slipped through the net, this one. We did a plain film. There was nothing on it. So I suspect it was something at the time, maybe under the sheet or something that the patient was lying on. But yeah, so look out for those kind of artifacts that might be there that are obscuring the view. Sometimes there's metalwork. If there is, we can exclude those. The radiographers can blank those out. But you tend to or avoid scanning altogether. And if you've got a hip replacement, you just wouldn't bother scanning it. There's no point. But sometimes these things crop up unawares. So there we are. Watch out for artifacts. This one here, again, someone with very high bone density, is a man, is a new diagnosis of giant cell arteritis on steroids. Pick that up, but quite low bone density in the hips and high in the spine. We've talked about PSA and other things as well. Degenerative change, which we need to include these other things too. But with a low bone density in the hips here, we're seeing minus 2.5 is the definition for osteoporosis, standard deviations. That's T-score less than 2.5. So bordering on osteoporosis here, absolutely does look very degenerative. But I think someone has been started on steroids pretty clearly, really bordering on osteoporosis with that T-score of minus 2.4. I think it doesn't, that will be someone I would say risk factor for osteoporotic fracture is high here, and I would treat this patient with a bisphosphonate, or providing there are no contraindications. So they're really approaching osteoporosis, and the degenerative change means that the spine probably is not very helpful to scan this time. It doesn't give you any useful information. Check your PSA and stuff, but my clinical recommendation would be based on the fact that bordering osteoporosis and steroid risk factor, go for it. Jessica's very good comment here. I would advocate the use of the FRAX score, which can tell you unequivocally about that. So that'd be helpful. So I can steroids. Yes, the spine is the one that we would say affects more, but both can be affected. The same with aromatase inhibitors. We've got a lot of patients with breast cancer start on aromatase inhibitors, and those patients our cutoff is, we are saying around -2. If you've got a T-score of -2, I would tend to then recommend a bisphosphonate. to our oncologists, whoever's treating that patient, but that tends to preferentially affect the spine. Okay, so case 8. Let's move on. This is a lateral vertebral assessment. Ooh, sorry. This is lateral vertebral assessment showing you that the whole spine, and compared to lumbar spine, it's a minuscule amount of radiation. So it gives you useful information, providing there's a pretty clear fracture, as I showed you in that picture earlier. And you can actually see here, look at that. It gives you this computer generated readout indicating at T12 we've got this fracture here. That wouldn't be picked up on a DEXA, because of course DEXA scan is the lumbar spine, but you can quite clearly see the lower lumbar vertebrae, lower thoracic vertebrae are often affected too, which gives you that kyphosis. So pretty clearly a T12 fracture. Now, this is a patient who's been scanned numerous times. We know they're in the osteoporotic range because the T-score has been consistently less than -2.5 over time. This is the scan result we've had this time. So case 8 really describes this lady, and the history is a sharp back pain, queer history, although they can be asymptomatic. But this sharp back pain was 6 months ago, didn't seek advice at the time, obvious fracture. Now, I will tell you, this patient had 5 years of bisphosphonate treatment and was on a drug pause, used to be called a holiday, a drug pause from alendronic acid. So what would we do? Any thoughts about the drugs that you might pick? Just pop a drug in the chat and tell you which one would I think of first to use. Roma, absolutely. So if you use romosozumab, I would. It's a fantastic drug, really helpful. A year of treatment, and that would be one of the reasons I would scan it in a year, just to see the effect of it. But we're seeing very good results with romosozumab, and then we can restart bisphosphonates again. If the T scores are low enough, we can think about the anabolic drugs, teriparatide, abaloparatide, and some of these other ones as well. You have to have at least 2 fractures. It's nice. There's nice guidance on it. And if you're the more elderly patient, the threshold for using it is slightly less, with a T-score of less than -3.5. And the younger patient, the younger woman, the T-score has to be a bit lower than that. But we were in that stage before romosozumab where we were a bit stuck. You bisphosphonates, where we tried them, they failed on them. Might have denosumab, which is another very good drug. But besides that, the cupboard was relatively bare in terms of what we had, but it's great to have a new drug on the block that we can use in romosozumab. So increasingly our patients in the clinics are receiving this drug, and the results are just amazing. I mean, it's absolutely brilliant. I mean, teriparatide is very good as well. It's just, but these drugs are more expensive, obviously. Anyway, I shall move along. Case 9. So this is a 44-year-old lady with a very low, well, just have a look at the scan. I'll tell you there's a very low alkaline phosphatase. So I probably don't need to tell you, but you can pop something you think it might be in the chat. You probably don't need the DEXA scan to interpret that. But someone's mentioned, Anish mentioned, that our SERMs not really useful. We don't use many of these anymore. I mean, they might help a bit with the spine. They're not. The evidence is they're not particularly helpful for the hips. When you're stuck, in the old days, I probably did use them a bit more. But Evista, some of these estrogen analogs, tend to be much less excellent. Hyperphosphatasia, but I'm preaching to the converted here. You guys would pick that up probably. Probably the group of resident doctors who pick that up quicker than most others. So no, I'm very glad to see. Very good. Hypophosphatasia is the diagnosis, and this was sent on to the relevant team to sort out, and from there. So that was the 9th case. Got 2 more to go here. I hope I'm going to have time to do these and just finish off with fracs. So this is a 21-year-old lady, normal bone density, has a fracture at T4. So right on this sort of young age, with a fracture at T4, and no obvious trauma. That is very unusual, isn't it? So that would be someone you may want to MRI. The other piece of information is she's 109 kilograms. So again, someone you may be seeing in your weight reduction clinics, or maybe going to think about treatment for helping with obesity. but there are a fair number of patients who are younger with metatarsal fractures who are obese, that have seemingly relatively low trauma. But obesity, as I say, is a risk factor. What I do see a lot of is ladies referred to me from the oncologist with breast cancer. And we know that obesity is a risk factor for that, and a risk factor for osteoporosis. So I routinely will make sure I'm checking the weight on these patients and recommending weight loss, which would help with everything in terms of their management. So this is simply someone young with a fracture. Anyone younger with a fracture, in fact, more old as well, I would do the panel of investigations, use knees, liver function, thyroid function, recommend celiac screen. More elderly patients, obviously myeloma screen, vitamin D levels, and men, I check 9am testosterone, SHBG, 9am cortisol, throw all those things, full blood count, ESR, so the usual investigations. I quite often, I've got a short code on my reporting to say, press that button and it comes out with all the recommended investigations. Of course, get a fair number of patients with celiac disease, and there's a risk factor. Interestingly, as you might know, a lot of my patients referred in with celiac disease are also overweight, which is, perhaps not where we traditionally think of a patient with celiac disease, but I would recommend that on everybody as well. So we do pick up quite a lot of stuff in the osteoporosis clinic, just doing these things or recommending on the DEXA report that the referring clinician does this before they come into the clinic, and then we can make a one-stop diagnosis and management plan. So excellent. Let's move along. Case 11. This is my last case. This is a 46-year-old lady whose mother had a fracture of femur, age 63. So strong family history. So how would you manage that? So she's got really lowish bone density here, minus 1.4, minus 1.6, and in the normal range in the lumbar spine. So what would you do? FRAX, yeah, I think so. Get a FRAX analysis and see about the risk factors. FRAX is likely to say, just lifestyle measures for now. Obviously, not smoking, moderating alcohol, plenty of exercise, looking at your vitamin D in your diet, calcium in your diet, and those kind of things, which I'd recommend on pretty much all DEXA scans anyway. But those lifestyle measures are important, but she's got strong family history, and I'd probably, absolutely, HRT, really good thing to think about, providing, again, there's no contraindication. She may well have had an early menopause, this lady, and maybe her mother did as well, so that's an important factor. But I would probably just get another DEXA scan in maybe in 5 years' time. I mean, the absolute risk of fracture at a younger age is smaller, and the FRAX would probably indicate that. But I would probably think about, just on my report, saying just do another DEXA when she gets to 50, maybe 55. Let's just keep an eye on it, and we'll take it from there. But giving people bisphosphonates for a prolonged period of time, no one really knows. If I start someone, we used to put people on it, patients with lupus and patients with rheumatoid, in their 20s and 30s. But it's a drug that goodness knows what, that effect will be. We know about, obviously, atypical fractures, need to avoid those. But you have to be, with a younger age group, I think we've gone away from just sticking people on bisphosphonates. But the FRAX score is important, and this gives you the absolute risk of fracture. Incredibly useful. Now, hopefully, most of you will use this in your clinic. The new look of the FRAX score is quite nice. You obviously put in these risk factors here and calculate a risk. If you haven't got a DEXA scan result, you don't necessarily need one. It'll tell you that it'd be useful to have one. So in a GP surgery, they could do this without a DEXA, but quite often it will show that you probably need to do one. So this is the kind of thing that comes out of it. So you get a print. This is the NOG guidance. So once you've done it, calculate it. It will. I'm not sure I've got time to go into great detail, but it will give you a recommendation based on the figures that have gone on. It's incredibly useful. I've compared my reports in the old days with what FRAC comes up with. I'm glad to say they're pretty much aligned, but yeah, but this is continually modified for different populations and really useful. So the NOG is basically UK based, which is an overlay on top of FRACs. But if you haven't got a DEXA scan, this orange zone appears, which shows you should measure the bone density to make a determination. And when you measure the bone density, it takes away you put the T-score in the neck of femur in, and it takes away the orange zone. This patient's right on the borderline anyway, so you've got to make a call clinically. But it gives you an indication of where to treat. So if you haven't discovered the FRAX tool, just go for it, have a play with it. Put your granny in, whatever, and see what the risk is. It's surprising, how useful this is. And in clinic, I would talk to a patient, I'd talk to them about the risk factors, and we do a FRAX score together in the clinic. And it's really helpful for a patient, particularly when you're trying to persuade them that treatment might be helpful, because a lot of them can be quite reluctant. So it's basically a decision tree based on that. Again, it's on the site. I recommend the Royal Osteoporosis Society if you want more information, really useful for patients and for clinicians as well. It's got some great resources on there, definitely one to recommend. So I'll just finish off from 10 o'clock. Is common, huge cause of morbidity and mortality. We can manage it with risk factors, risk factor based management, but sometimes we need to look for those risk factors and look for those underlying causes. DEXA is the mainstay of our diagnostic tools, but it's not absolutely necessary, and it's not the end of the story. There are other things as well. I think I haven't mentioned falls risk is a massive thing that will increase the risk of fracture. And if you look at the FRAX website, you can see that there's a bit of an accelerator on the terms of lowering the threshold for treatment based on falls. And if you've got a good falls clinic, community falls service, I always recommend patients are seen there with my orthogeriatrician colleague who runs that. So that's the end of the talk. I'll stop sharing my screen. I'm sorry I've run out of time for questions, but hopefully we've kept it interactive, lots of cases, and you've learned a bit today, hopefully. But thank you so much.
Thank you so much, Professor Wallet, for doing that, and you answered loads of questions during the talk, which was fantastic. So yeah, thank you very much. Thanks so much for joining us.
Okay.
So
Have a good day.
yeah, so I'll move on now to Dr. Natalia Gack. I'm just gonna one sec. We'll just put this across. I think I've made you a host, Dr. Gack, so you should be able to share your screen.
Thank you. Let me just.
That's okay. And welcome. So everyone, Dr. Gack is a rheumatology registrar, I understand, and you've undertaken a PhD on this very topic. Is that correct?
Yes, that's correct.
Fantastic.
Sorry, can you see my screen?
Can see your screen and can hear you.
Yeah.
It's not.
Okay, fantastic. Can you see the first slide?
Yeah, that's fantastic. So yeah.
Okay, just give me a second. Right. So thank you very much for the kind introduction, Matt, and good morning, everyone. So it's a real pleasure to be here today and to talk about the pregnancy and lactation-associated osteoporosis. The slide should be moving. Here we go. So I'd like to start with outlining the main objectives of the session. First, we'll look at the pathophysiology of PLO. Secondly, we'll go through the key clinical features and how we diagnose PLO. And PLO, which is a pregnancy lactation associated osteoporosis abbreviation. And finally, we'll review the current evidence-based treatment options available for pregnancy lactation associated osteoporosis or PLO. I'd like to begin with a brief overview of how bone changes during pregnancy and lactation. On this figure on the left side, you can appreciate changes that occur during the pregnancy, and the right side shows the changes occurring during the lactation. So during pregnancy, calcium absorption increases to support the growing fetus, but this is balanced by higher urinary calcium loss. Elevated estradiol and calcium absorption suppress PTH levels, while parathyroid hormone-related protein produced by placenta and breasts rises to additionally support to mobilize calcium for fetal growth. During lactation, calcium absorption returns to normal, so the body relies more on bone resorption to provide calcium for breast milk. And this makes lactation a much more resorptive state. So bone turnover markers, CTX, P1-P, and bone mineral density reflect these changes. So during pregnancy, bone resorption markers rise, while bone formation markers remain low initially, but increase by term. During lactation, as it is predominantly resorptive state, bone resorption markers increase significantly, along with a comparable rise in bone formation markers. Overall bone density falls slightly in pregnancy, around 4 to 5%, and declines more in lactation, especially in the lumbar spine, where losses can reach up to 10%. So this diagram shows the trajectory of bone density during pregnancy, lactation, and after weaning. And you can see that both pregnancy and lactation reduce maternal BMD, but lactation has a much bigger impact because the skeleton is actively demineralized to produce breast milk. Importantly, this bone loss is usually rapid and fully reversible once breastfeeding stops. The post-lactation recovery phase is driven by falling PTH-IP levels, the return of menstrual cycles, rising estradiol, and drop in prolactin, all of which promotes bone formation as well. Although bone loss during pregnancy and lactation is usually fully reversible and does not cause fractures, unfortunately, in some women, fragility fractures do occur during this very vulnerable phase of skeleton loss, bone density loss. This condition, and if this does happen, the patient develops pregnancy and lactation-associated osteoporosis, or PLO. And this MRI image illustrates the typical pattern of vertebral involvement in PLO, with fractures from T12 down to L5 fractures. PLO results from multifactorial pathogenesis, including pregnancy-induced bone loss, pre-pregnancy low BMD, mechanical stress on maternal spine, and ligament laxity associated with hormonal changes. Additional risk factors include reduced physical activity during growth years, a strong family history of osteoporosis, and genetic mutation in LRP5 and WNT1. So PLO is defined as a rare but often severe form of early onset osteoporosis, where young women present with floor trauma or even spontaneous fractures, most commonly vertebral fractures during pregnancy and lactation. The true incidence of PLO is still uncertain. Recent data from Japan estimates around 416 cases per million births, while a study from Edinburgh reported an incidence of about 6.8 per 100,000 pregnancies. These figures are noticeably higher than the older estimates of 4 to 8 cases per million pregnancies, and likely reflects increasing awareness and better recognition of the condition. So overall, the variation in reported incidence highlights actually the limited number of robust epidemiological studies in this area. The most common symptoms of PLO are severe lower back pain and a noticeable reduction in height, both caused by vertebral fractures. Vertebral fractures occur in about 90% of PLO cases, which reflects the greater bone loss in the spine compared to the other skeleton sites. But other fractures can also occur, including hip, sacrum, humerus, and ribs. The case reports have been reported on those fractures in PLO as well. Women often present with multiple fractures. Mean number can reach up to 4 to 5, forming of what we call a cascade of vertebral collapse, and thoracolumbar level being the most affected one. PLO most commonly occurs in the first pregnancy and typically presents after delivery or during the lactation period. Most affected women have no prior diagnosis of osteoporosis or history of low bone mineral density, and no pre-pregnancy BMD measurements as well. So how should patients with suspected PLO be investigated? In a woman with a suspected PLO, the red flag obviously is acute onset of new back pain or height loss during late pregnancy or postpartum. Imaging should start with X-ray of the thoracolumbar spine after delivery, or MRI if patient is still pregnant, which is safe. MRI is safe in pregnancy. So if a vertebral fracture is confirmed on X-ray following delivery, patients still can follow and have MRI, as it also can add an extra information and to distinguish new from old fractures. Again, if the fracture has been confirmed, following this, patient would have DEXA to measure bone density, and blood tests, full assessment, history taking. The blood test will include vitamin D, bone profile, and screening for secondary causes of low BMD. Management of PLO begins with conservative measurements of treating the back pain caused by vertebral fractures, using appropriate pain relief, and advice on safe mobility once the fractures have healed. We also discuss with women the potential benefit of stopping breastfeeding, which can help maximize early recovery of bone density and prevent further bone loss. Monitoring the return of menstrual periods is important, as again, it signals recovery of hormonal support for bone. And finally, we correct any deficiency in calcium and vitamin D with supplements, ensuring that the body has the necessary building blocks for bone recovery as well. The indications, type, and duration of treatment for low BMD in PLO are not really defined, and there are currently no national or international guidelines. Some clinicians take an observational approach or delay treatment, relying on the natural recovery of bone density after delivery or weaning. While many women do show improvement this way, anti-resorptive or anabolic therapies have also been used. For example, bisphosphonates have been reported in case reports, but they are generally avoided in women planning future pregnancies because they can remain in bones for many years and cross the placenta. Denosumab has a half-life of about 25 days, so its levels gradually decline over 4 to 5 months, and it does not accumulate in the bone like bisphosphonates. However, stopping denosumab can lead to rapid loss in bone density, as we know, and an increased risk of vertebral fractures, which is particularly concerning in women who have already presented and had vertebral fractures. So treatment with denosumab also require a careful follow-up exit strategy, which includes involving bisphosphonates. So again, it's not ideal for young women who may want to have some more children in the future. So therefore, teriparatide, recombinant human parathyroid hormone with an anabolic effect on bones and half-life of hours and a good safety profile, is frequently a preferred choice for a woman diagnosed with PLO. And to date, there are only 3 retrospective studies which investigated use of teriparatide in PLO patients. And one of these studies was conducted by Hong and colleagues in South Korea, and it did demonstrate that at 12 months, mean lumbar spine BMD increased by 16% in 27 women treated with TPD. You can see the black bars are the group of a woman treated with TPD, and the gray bars are the controls, so the woman who had received a vitamin D and calcium supplements only. And in 5 patients treated with calcium and vitamin D, with vitamin D, they gained only 3.5% in the lumbar spine. So in addition, BMD improved substantially by 5.4% and 5.2% in the femoral neck and total hip respectively in teriparatide treated women versus 2.5% in women on supplements only. So overall, both groups were recovering, but those who took teriparatide gained more BMD. And finally, I will like to present 2 real live clinical cases, which I hope will help illustrate the key features and the management principles in PLO. So the first case is a 33-year-old lady. She's fit and well with no history of fractures. In 2018, she became pregnant for the first time. She had a normal pregnancy and normal vaginal delivery. However, 10 weeks postpartum, she developed acute low back pain while she was lifting her baby. She was referred to physiotherapy, who diagnosed the pain as related to the post-pregnancy, post-delivery, and pain has improved within 2 months. The patient at that point did not report any height loss, and she continued to breastfeed for 13 months. 2 years later, she became pregnant again. She had a normal vaginal delivery, and again, 3 months postpartum, she developed a new severe low back pain. She was seen a few times by her GP, who unfortunately dismissed her back pain and just advised her that the back pain is consistent with the post-delivery period. However, because the back pain persisted, she was very debilitated with that. She was bedbound for several weeks. She went and saw privately sport and exercise medicine consultant who organized an MRI spine. And that's her MRI spine, thoracolumbar region, and it does show compression fractures. It also showed that she has got an old compression fracture at the level of L1 and new compression fractures at T12, L2 to L5. So most likely the old one happened during her first pregnancy. And this is her DEXA. So obviously she does have a low bone mineral density for her age, with the Z-score of minus 3.9 in the spine, and Z-score of the total hip of minus 2.3, and femoral leg minus 3.1. She was investigated for other secondary causes of low BMD, and those were normal. Patient stopped breastfeeding. She, in total, by that time, she breastfed already for 10 months, and she started taking vitamin D and calcium supplements. She declined offer of starting teriparatide treatment. And this is her follow-up DEXA, and you can appreciate that over a period of 13 months, even without teriparatide treatment, she had, after stopping the breastfeeding, she had an 11% increase from baseline in her spine, and also 3.9% increase from baseline to 13 months in her total hip. The second clinical case with slightly similar presentation, but slightly different management. She's a 34-year-old fit and well lady with a history of previous traumatic fracture, but this is following a fall from 10 stairs. She became pregnant for the first time. She had a normal vaginal delivery in May 2021, and following delivery, 2 weeks following the delivery, she developed severe back pain, which has been persistent for at least 2 months. Sorry. Unfortunately, again, she was dismissed on several occasions when she presented to GP with those symptoms, even by the physiotherapist. And she just took initiative herself and went and had an MRI spine done privately. And this is her MRI image, and it does show several compression fractures, so what we call cascade of compression fractures from the T5 to T12 and L2 to L5. Because she was very, again, the DEXA also showed low bonding neuron, low BMD for her age, with the Z spinal score of -3.7 and total hip -1.4. Because she had several multiple fractures and she was planning for the second pregnancy in the future, she actually was very happy to go and have the treatment with teriparatide. And you can appreciate that over the period of 22 months, she had a very good increase in her BMD of her spine of 25%. And also good, but not as good as in the spine. In the hip, she gained about 8%. So in summary, PLO is a rare but incapacitating disease occurring in young women in late pregnancy or following the delivery and or lactation period. It is important for clinicians to be aware of the potential for the fractures to occur during the pregnancy and lactation to enable rapid diagnosis and appropriate further investigation and management. And the best approach to the treatment of women with PLO remains to be determined and should be a focus for the future research. Thank you, and I'm very happy to answer any questions.
Thank you very much, Dr. That was fantastic. Really great. What I've done is because everyone's muted, I've told people to put their questions in the chat. Are you able to see the chat?
Okay.
On the side. I can read the questions to you otherwise if
yeah, I can see that. Yeah, also I'm not really used to, not in the UK as yet. A low LP. Is that for me or sorry, where?
Sorry,
Yes, if you don't mind. I'm not sure when did they start.
That's right. I'll read some questions. So, the first one was: does hyperlactin in pregnancy have a role in the loss of bone mineral density in pregnancy?
Yes, as I presented in the pathophysiological, the physiological changes during the pregnancy and lactation. Yes, it does.
And they asked, do you look at Z score or T score? Is there a threshold for considering treatment with bone protective medications?
So in younger women, we'll look at the Z score. And what is the threshold for considering treatment with bone protective medication? Bone protective medication, what exactly? The treatment for the low BMD, or they're referring to vitamin D and calcium supplements? Sorry.
I assume that they're thinking about not just calcium and vitamin D supplements.
So if we're talking about anabolic, there is not a specific threshold. You usually just make a decision looking at the clinical picture, looking at the bone density scan, and what is the plan for that specific woman in the future. If she's considering more pregnancies in the future, then yes, obviously, you will want her bone density to gain slightly quicker than just wait for years until it's going to recover completely. Because before the second pregnancy, you would she would need to have a good bone density. Because we know that once she's going into the second pregnancy, the bone density will decline again.
Fine. Okay. And another question here, how do we prevent PLO? Is it possible? And is there a particular group of women that we think are more at risk?
Yes, that's a very good question, actually. So yes, so the women who are at risk, obviously, those who have already been diagnosed with the conditions which can potentially decrease bone density, such as, celiac disease, rheumatoid arthritis, other inflammatory conditions, Crohn's, or so all those conditions which can potentially reduce the bone density in a young woman. Yes, we need to be cautious, and I would definitely. I mean, they should have at some point a DEXA anyway, just to see what they baseline. But yes, those are at risk. I'm sorry, what was that? The second part of the question. Sorry, I forgot.
Is there any way to prevent PLO?
Unfortunately, because we don't know the causes, like specific causes yet. Unfortunately, I don't think. If we're talking about the healthy woman, yes, they need to make sure that even before the pregnancy and during the pregnancy, they need to be supplemented with vitamin D and calcium. And though the vitamin D and calcium levels should be tested during pregnancy, the same as we're testing, for example, iron level. This is one of the options. Yeah, but until we don't know the specific causes, unfortunately, I don't think we can.
Another question, is there a difference in risk between fully breastfed and then weaning, or women who breastfeed for comfort, so just once or twice a day? And is there a role for measuring prolactin levels?
Is there a difference in risk between fully breastfed plus weaning for women who are breastfeeding for comfort? No, there are studies which show that the longer you breastfeed, the longer the recovery of the BMD will happen. Yeah, does it make sense? So the shorter period of breastfeeding will increase the chances for the BMD to recover sooner and quicker. So this is to answer the first question. Is there a role of measuring prolactin level? Measuring prolactin level during the lactation? Sorry, it will be high anyway, so
Yes,
I don't think there is. I don't think, yeah. From my perspective, I don't think we are not measuring the prolactin level in those women. But maybe I misunderstood the question, sorry.
And is there any long-term follow-up in the sense that are women who develop PLO more likely to develop bone disease later on in life?
In a long term. So this is again a very good question, and because we don't have too many studies on women with PLO who would have, a long follow-ups for this, you need to have, a study with the follow-up of 2 or 3, more than 5 years, I guess, and it depends on what bone disease you're related to. So. The answer is I don't know if those women will develop other bone diseases, but I think, again, you just need to have more studies, more research on this specific question, but that's a good question.
Fine. And
sorry, to add on that, so the woman with PLO, if they go into the second or third or any other pregnancies after they have been diagnosed with PLO, they have 20 to 25% of chances to develop fractures again. So maybe that's what you were referring to. If the fracture will reoccur in the future pregnancies, yes, there is like a 20-25% of that. But this was confirmed on one study, and more information and more studies are needed on this.
Fine. Lots of questions coming in.
Yeah, happy for questions.
Does their bone mineral density return to normal post-treatment? Are they at a higher risk of developing osteoporosis post-menopause? I think that was kind of the last question as well. And then how are these women monitored long term at the moment? Is there an approach to monitoring them?
So does the BMT return to normal post-treatment? So every woman responds differently to the treatment. It's again depends on the baseline BMT prior starting the treatment, if it's very low. So we know that by 12 months, they should gain in bone density up to 20%, by 24 up to 30%. But again, every woman responds different to the treatment. Sorry, the second question was, are they a higher risk of developing osteoporosis postmenopausal? So again, we don't have the information, we don't have the data specific on this question. If we are referring to normal population, to healthy women who don't develop PLO, there are studies showing that actually pregnancy and lactation does protect and does reduce the risk factor, does reduce the risk of, it's not, I would say pregnancy and lactation is not a risk to develop an early osteoporosis once a woman becomes menopausal. I'm not sure if it does make sense or not. So pregnancy and lactation is a protective phase, a protective period for women once they become osteoporotic. So it's not like those women who were not pregnant, they have a higher risk they have a lower chance to become osteoporotic early compared to women who were pregnant. So pregnancy is, in some of the studies show that it's a protective risk factor for early osteoporosis. Sorry, the second question.
I'm probably gonna have to stop you, Dr. Yak, because we need to move on.
Yeah.
If that was a fantastic talk and something that I think that lots of people aren't really aware of, and I'd never heard it before starting chemical pathology at all. If you're happy to sort of write some answers in the chat to some of the questions, if you've got a moment, that would be fantastic. If you need to rush off, then no worries.
Yeah, I'll do my best.
Thank you so much.
No worries.
Thank you so much again. I think I've so the next talk is kindly being given by Professor Alexander Komnenos, and is on the approach to the patient with low bone density. I think I've allowed him to unmute, and he's sharing his screen. So hopefully that works. I can't hear you yet, Prof.
Hi, can you see me?
Yes, I can't see you, but I can see your screen, and we can hear you.
Now can you see me? Wait, okay. Sorry.
Oh yeah, I can see you.
You can see me. Okay, fine. So firstly, thank you very much for inviting me to speak today, and thank you for giving the opportunity for Dr. Gak to do some good Viva practice with all those really excellent questions. We can talk about that as well if we have time at the end of my session. Professor Wallet has covered some of the topics I'm going to talk about, but I want to sort of focus on some useful tips and tricks when you're trying to assess a patient with low bone density. And remember, over half of women in Europe have low bone density and they're not being assessed. So there's a real gap in the market really here. So it's very important that we improve the education on the assessment of low bone density. So today we'll talk about assessing patients with low bone density is the overall topic. We'll talk about bone changes during life in women and men. We'll talk about the key points to focus on in history and examination, and then the key investigations and why we're doing them. How do I decide if a patient needs treatment? So I'll just go into FRAX Plus in a bit more detail. Some little tips on DEXAs and just talk briefly about imminent fracture risk, which basically identifies the need to treat these patients early. So starting with the bone changes during life. So you've seen this graph before. So as we grow up until the sort of age of 18, our bone mass also increases. But you can see we've finished growing, but our bone mass continues to increase. So it's like putting up the scaffolding and then filling it in. Okay, and so we reach a peak bone mass between the ages of 30 and 40. And that's the peak bone mass to which the T-scores are referring to. So the T-scores are the number of standard deviations away from the peak bone mass in women. And you also use the female range in men as well. And then after the age of 40, unfortunately, our bone mass decreases about 1% a year in men, which sort of correlates with the declining testosterone levels. And similarly, in women, there's that more dramatic drop, as you can see, perimenopausally and postmenopausally, about 2% a year for 5 years. And so it's really important, as you can see in this graph, to get to the highest peak bone mass possible because it's always downhill afterwards. Okay, so anything during your life can affect your bone mass and where you are later on in life. Okay. Obviously, these changes in bone density translate to increases on the left in men and on the right in women in resulting fractures from that lower bone density. So let's talk about the key points to focus on in the history and examination. So quick question. So you were assessing a 55-year-old woman in clinic. She had a DEXA scan after sustaining a fragility fracture of her humerus. So that's a major osteoporotic fracture. Her DEXA scan shows osteoporosis in the spine and osteopenia in the hip. Which of these has likely contributed to her low bone density? Is it A, alcohol consumption of 1 unit per day? Is it B, low dose statin use? Is it C, menarche, aged 18? Is it D, no previous pregnancy or breastfeeding? Or E, regular weight-bearing exercise? So let's see if I can see the chat. You just put in your answers in the chat. And almost everyone has gone for C, which is the correct answer. Good. So essentially, alcohol above 2 or 3 units per day can poison osteoblasts. Okay, 1 unit a day is probably okay. And if you poison the osteoblasts, these are the bone building cells, they obviously have an impact on bone mineral density. High dose statin use is associated with low bone mineral density due to interference with sex steroid precursors, essentially cholesterol. Menarche aged 18, of course, menarche is usually 13 to 14 years, so that delay in getting estrogen to the skeleton can cause detrimental effects on bone mineral density. No previous pregnancy or breastfeeding would not be a risk factor of significance to bone mineral density, and obviously weight-bearing exercise is good. So why is it important to really hunt for any other secondary causes and risk factors for low bone density? Because you may be able to find something, and we've found many patients in our clinics with other disorders which are impacting their bones, and obviously you want to treat these underlying disorders first. So in women, about 30% will have a secondary cause, and in men, a higher number, 50 to 80%. So my message to you is consider secondary causes, particularly when the bone density is very low, especially the Z score, because that's outside of your reference range. The Z score is below -2. In your younger patients and your men. Okay, so 3 things to consider and really hunt for secondary causes. So how are you going to identify them? Well, history, examination, and investigation. So starting with history, you want to know if they've had any previous fragility fractures. It's like if you've had a stroke, you're more likely to have another stroke. Any severe illness during lifetime because of the cytokines, the interleukins, the immobility will have detrimental effects, will affect that curve, the gradient on that bone mass graph I showed earlier. Anything that reduces the duration of good estrogen to the skeleton will have negative effects. We talked about pregnancy and breastfeeding and the problems that can be associated with prolonged breastfeeding in some patients. A history of low BMI, and that can be in the absence of amenorrhea. So a low BMI with normal menstrual cycles is a risk factor just because of the weight loading on the skeleton. Moving on to the past medical history, obviously malabsorption. You've got any inflammatory disorders. Again, that's the cytokines and interleukins, which are interfering with bone remodeling. You've got all your endocrine disorders, so diabetes, where you've got high circulating glucose, and that can interfere with the matrix. They have very poor bone quality. Patients with diabetes, sometimes their bone density is not too bad, but the quality is not very good. And obviously, DEXA does not assess quality. You need to do biopsies for that. Other endocrine disorders, so hyperthyroid or hypothyroid, so too fast bone remodeling or too slow bone remodeling. Hyperparathyroidism, where the PTH is chewing up the bone. Growth hormone deficiency, too much steroids or low testosterone estrogen will all detrimentally affect bone mineral density. There are other disorders, so multiple sclerosis. These patients often have high-dose methylpred. They have immobility. Myeloma and MGUS, so that's like a bone inflammatory condition. We've picked up several patients with myeloma in our clinics, and MGUS. Mastocytosis, so that's excess mast cell activity, and it's going to occur within the bone marrow, causes sort of low-grade inflammation, which interferes with bone density. We have about 11 or 12 patients here with that, and we've picked up 2 patients with it. They don't always have skin signs. It can just be internal in the bone. Sarcoid, as an inflammatory disorder, often treated with steroids. Collagen disorders, for example, osteogenesis imperfecta, HIV, so the virus itself, as well as the treatments, can interfere with bone remodeling. Hypercalciuria, we picked up many patients who essentially are peeing out their skeleton, peeing out a lot of excess calcium, which comes out of their skeleton due to a renal leak, typically. Hypophosphatasia, not to be confused with hypophosphatemia. So hypophosphatasia is low ALP activity. And ALP, as you may know, basically breaks down an inhibitor of bone formation. So if you haven't got enough ALP, you have more of this inhibitor of bone formation, and you have impaired bone mineralization. Kidney stones and dental issues are often flags of other disorders going on. Dental issues, maybe there's something congenital going on. In the drug history, so we've got steroids, of course, aromatase inhibitors, SSRIs, so the serotonin receptors on bone, Parkinson drugs, antipsychotics, high-dose progesterone, especially sort of progesterone depot preparations, GnRH agonists and antagonists, because they essentially cause medical castration, heparin and warfarin, especially heparin. There's a lot of women who actually develop PLO because they have heparin during the pregnancy or postpartum for one reason or another. Anticonvulsants interfere with vitamin D metabolism. Antiretrovirals, I mentioned earlier. You've got things like tacrolimus are negative on bone. Proton pump inhibitors interfere with calcium carbonate absorption from the stomach. So calcium carbonate is the form of calcium that is in most preparations, your Adcal, Accrete D3s, things like that. And it really needs an acidic stomach for its absorption. I don't stop PPIs, but I do make sure that they definitely take their Adcals. Or if they can afford it, they can go and buy calcium citrate, which does not rely on an acidic environment. But that's not available on the NHS. They have to go to a health food shop. Dietary calcium. So you can use the Edinburgh Calcium Calculator, which is probably the most friendly one at the moment. Here at Imperial, Liz Nasuna, one of our FLS nurses, is developing a new, probably more friendly dietary calcium calculator, which will roll out soon. And then vitamin D deficiency is obviously important. Family history, especially want to know if there's a parental history of hip fracture, because that's a point of data input into fracs. Smoking's bad. It's the cadmium in smoke, and even vaping's bad. There's data that there's a 1.87 fold increased risk of fragility fractures reported retrospectively in those who vape. Alcohol, as I said, poisons the osteoblast, and obviously a history of falls will, buy you more chances to break a bone. And remember, falls is not entered into FRAX. One of the big negatives of FRAX is you don't put falls history into the basic FRAX. There is a FRAX Plus where you can add it in. So moving on to examination. So height, you really want to be looking at any significant changes from youth or between appointments. If there's more than 1.5 inches, 4 centimeters, something like that, then you may want to do thoracolumbar lateral X-rays to look for any fractures. Because don't forget, up to 50% of vertebral fractures are silent, as in the patient does not report pain, does not report any significant trauma. Okay, they just happen without them realizing it. Any other pathologies you're looking for, especially Cushing's, are they clearly Cushingoid? Vertebral examination if they're complaining of back pain, looking for any distal neurology, and falls risk assessment in some patients may be worthwhile. So what investigations should you be sending? Well, on the left, you can see here that each clinic appointment, our patients will have their renal function checked. They'll have their PTH checked. Just a reminder, in primary care, nice guidance is not to do PTH unless the calcium is above 2.5. And you probably are fully aware why that is, because of the avalanche of secondary hyperparathyroidism of no consequence. Adjusted calcium, phosphate, vitamin D, ALP. And then we do bone formation markers. So these are made by the osteoblast, and bone resorption markers. These are made by the osteoclast. Here we do bone ALP and P1NP, and we do urine NTX. So we get these each clinic appointment. They're most useful for monitoring treatment rather than in the diagnosis, but we will do it at first presentation as our baseline. DEXA scanning is between 2 and 5 years, and as I mentioned before, we may get thoracolumbar X-rays, especially if there's significant height loss, kyphosis, or pain. If the patient is new to our service, Jacobella, who's our bone nurse, will organize a panel of new patient bloods. These typically include a full blood count, ESR for undiagnosed inflammatory conditions, LFTs and sex steroids in some patients. I'll put prolactin in brackets there. Be a bit cautious because you don't want to pick up trivial increases in prolactin. I would only send it if I found unexpected hypogonadism. Thyroid function, protein electrophoresis, and celiac screen. We picked up plenty of new celiac diagnoses in our bone clinic and our fracture liaison service. Now, in some cases, we don't really find enough in our history and investigation so far to explain the very low bone density. So we will proceed with second line tests for other slightly rarer underlying disorders. So we may look for hypercalciuria, we may look for renal tubular acidosis. Remember, a slightly acidic body that will pull out bicarbonate out of the bones and reduce bone density. In some cases, we may look for subclinical Cushing's. Again, be cautious with that, as well as your prolactins. And you really want to have good evidence, a high pretest suspicion. Serum tryptase, as I said, we've picked up some patients with mastocytosis, and for what it's worth, you could do an ACE if there's some sort of respiratory history and you think there may be some sarcoid. So if you do identify a secondary cause, then obviously you want to refer the patient to the appropriate clinic for assessment of that underlying disorder, and perhaps you might wait before starting treatment to get more information back from that department. So how do I decide if a patient needs treatment? And Professor Wallet has alluded to this, and it's basically by estimating fracture risk. So in a similar way to, you've got your Q risk 3 for determining whether you're going to put a patient on statins. You have FRAX here for determining if a patient should go on treatment. Most guidelines use FRAX. There are some other tools which I'll mention very briefly. the thresholds for intervention vary globally, and it depends on the availability and costs of therapies. In my practice, I normally will start treatment if a patient has osteoporosis, and if they have osteopenia, I will put their data into FRAX. So FRAX Plus has been used, as you can see here, well, FRAX and FRAX Plus has been used 45 million times. So it's very popular. It actually came out in 2008 from the University of Sheffield. So there's probably another couple of million that are not included in this counter. And it gives you the 10-year probability of major osteoporotic. So that's one of 4 sites. So that's the forearm, the humerus, the spine, or the hips, or hip fracture. Okay, so 4 sites for major osteoporotic. It's validated in independent cohorts. There's been, over 10 validation studies using this calculator. It generally assumes the patient has not had treatment yet, but you can always put in the details in if they had treatment just to get an idea of risk. As I mentioned before, there are some downsides. It is locked between the ages of 40 and 90. It ignores the number and the type of fractures, the falls risk, the dose effects of steroids, for example, and certain other underlying secondary causes. But with FRAX Plus, if you pay to use it, about €1 per adjustment, you can enter some of these things now. There are other calculators, Q fracture, which is sometimes used in the UK. You don't need a bone mineral density input for that, and Garvin, and that will give you some further information. So why do we need FRAX? So this is the slide that explains it really. So first, if you look at the red bars, so as your T-score gets lower, your risk, the fracture rate goes up. Okay, so that's clear, clearly clear why that would happen. However, if you look at the number of fractures, these are greater in the osteopenic range. Okay, that's the gold bars. And that's simply because there are more people who have osteopenia than have osteoporosis. So it's basically a numerical thing. So we really need a device, a calculator, to tease out which patients within the osteopenic range would benefit more from treatment. Okay, so most fractures. So, for example, half of people who come in with hip fractures actually have osteopenia. Okay, so most fractures occur in osteopenia. So how does FRAX work? Well, firstly, you enter the country of origin, and you can see there's quite a big difference between US Caucasians through to Turkey in their 10-year fracture probability, which I don't fully understand, but that's the data that has been put into the system. It's available for over 80 countries. And then you put in the age, and obviously as one ages, the fracture risk increases. It starts to drop off towards the end. That's because the patients don't survive long enough. They die of other causes, and so they don't actually have that hip fracture beyond there. And then you've got BMI. So here you can see this favors a BMI of 25. So if your BMI is 20 compared to 25, you have a 1.5 times relative risk of fracture. So it's better to have a BMI of 25 for your bones. And then there are other risk factors. So these are all with relative risks above 1. So these are risk factors, and that's with or without BMD information. You can see prior fracture, family history through to rheumatoid arthritis. Now, this is a really important slide. Okay, so here you can see 10-year fracture probability across the range of T-scores from 0, so similar to a 30 to 40-year-old female. And as you get worse bone, you undoubtedly have a higher risk in those with a T-score of -3. Now, if we add in that they've had a prior fracture, you can see that this has been a significant jump across all of the fracture probabilities across the full range of T-scores. Add in glucocorticoids, big jump again, and family history, a super high jump, such that a T-score of 0 with all of these risk factors carries a greater fracture probability than a T-score of -3 with no other risk factors. Okay, so this shows the power of this FRAX tool. So this is what it looks like when you open it up. you fill the various bits in. So I've got a 55-year-old lady here. She's got osteoporosis. Okay, so you put in the machine you're using, you put in the femoral neck bone density, and it gives you a T-score of -3. She has a 11% risk of major osteoporotic and a 4% risk of hip fracture in the next 10 years. And so you then click on the View NOG guidelines, that red box there, and it says treat. Okay, so you take the worst of these two. So you would definitely want to treat this patient. Now, same age lady, she's now got osteopenia. Her T-score is -1.8, so mid-range osteopenia. You can see much lower risks of fractures. This says don't treat. She's in the green in both of these. Okay, and you'd reassess. Now, what did this same lady, so everything, her BMI, age, and her femoral neck bone density are exactly the same, but we add in that she has had a previous fracture and a parent has had a fractured hip. And you can see there's been a big jump here. So she's still osteopenic, like the previous lady who was in the green, but now we've ticked a couple of risk factors and we click through and she's jumped into the dark red zone, so very high risk. Okay, so this shows the power of fracs. So don't always just rely on the bone density. So fracture risk tool is useful to decide on treatment, especially in your osteopenic patients. It's simple, evidence-based. You can turn your screen and show the patient, look, you're in the red, you need treatment. It's very good for convincing them, and it follows national guidelines. It's evidence-based. So just some very quick tips on interpreting DEXAs. Most of this was covered. Just remember that DEXAs are very low radiation. Okay, it's 3 hours of natural background radiation. So I say to my patients, it's like flying to Edinburgh and back. Okay. By contrast, X-rays of the spine and CTs are much greater radiation. So you get your two panels like this. And here I just want to point out, as Prof. Wallet has extensively lectured you on, the problems you need to sort of, here you can see in L4, there's this big white splodge. That's a osteophyte from degenerative changes. That's not adding actual structural improvements to the bone. It's just something on the outer surface of the bone. So you would want to ignore the L4 when making your assessment. You can see the T-score has jumped for the L4. So if you see more than one standard deviation difference in your sequential T-scores, do look at the images because there may be some degenerative changes, some error. So here you take the L1, L3 in the second sheet. Normally you can pick out, just the segment you want to use. So beware these false elevations. Then in the hips, the just main point I want to say to you is don't forget to input into fracs this number. So it's the raw score, the 0.675, because every machine is calibrated slightly differently and against a different reference population. So you shouldn't be putting in the T-scores because it's slightly different from the fracs computer to what your local T-score, your local T-score will typically use a reference population in your area. So the key components of bone strength. So this is why we shouldn't only rely on bone density. It is a component for bone strength, but there's also the microstructure. There's also the biomaterial properties. Remember, I mentioned that diabetics have very poor bone quality. And the geometry. So having a greater hip axis length. So that's the length between the femoral head all the way through to where it goes down on the femoral shaft. The longer that is, there's a higher risk of fracture. So there's a lot of other things that are important, but bone mineral density will give you about 50% of the information on bone strength. It is our commonly used tool, but it's not the be-all and end-all. So we shouldn't get too obsessed with DEXA. Look at your risk factors and things like that as well. So very briefly at the very end, I just want to mention imminent fracture risk. So this is an important graph. So this is your risk of next major osteoporotic fracture. So remember 4 sites. So that's the forearm, the humerus, spine, or hips, after having had an index fracture at time 0. Okay, so you can see in those first 2 years, you have a vastly increased risk of future fracture. So that's why it's very important that you treat these patients as soon as possible. This dotted line is what your risk is if you have never had a fracture. Okay, so that's my point here is treat your patients as early as possible. So we've covered all of these topics, and the final thing I just want to say is you can also identify patients with low bone mineral density using FRAX, but without the bone mineral density. So you can see it's blank here, but it will give you a risk, and it will put a marker potentially into the yellow zone, which would suggest proceeding to a bone mineral density assessment. You didn't have the yellow zone on the previous one because obviously you had bone mineral density. You can see here, so this patient, for example, because they've had a previous fracture, is now in the yellow zone. The patient before was not in the yellow zone, it was in the green zone because they had not had a previous fracture. So the key take-home messages are that bone changes during life, and this results in an increasing fracture incidence. It's very important that we assess the whole lifespan for risk factors and secondary causes. Remember, think about secondary causes when the bone density is very low, so below a Z score of -2, so that's outside of their age, sex, ethnicity matched reference range. Younger patients and men, refer on to the relevant department if you identify a secondary cause. DEXA scans, very low radiation. Remember, flight to Edinburgh and back. Look at the full images, but don't obsess about the bone mineral density too much because there are other important factors that determine fracture risk. We talked about putting the femoral neck bone mineral density into FRAX. We talked about the importance of starting early within those first 2 years post-treatment because of that high imminent fracture risk. And we talked briefly about identification. So really, I would suggest you do FRAX, especially in patients over 50 with an additional risk factor. So thank you very much for listening. If you want to watch any more videos, you can search for Alex's Osteoblast on YouTube, and there's some 11 webinars on various topics that you might find useful. Thank you very much, and I'm happy to take any questions.
Thank you so much, Prof. Komnos. And I hope everyone's seen your lectures online. It's always fantastic hearing you speak. There are a few questions in the chat. Is that okay? But someone was just asking if you can explain the imminent fracture risk graph again. And I have to admit, I had a similar question as to why in that first 2 year period people are so high risk. Are you pulling out the patients who have such bad or such high risk of fracture that they then go on to have another one so quickly, because it drops over that 2 year period? Why is that?
Yeah, no, that's a very good question. The answer is it's multifactorial. So it's factors as you suggest. It's things like delays in starting treatment, so that bone density doesn't get better. It's also the fact they've just fell over. They're more likely to fall over again before someone gets to the bottom. They have physio and things like that to improve their, or to lower their risk of falling, for example. And also the mechanical strain on the body from having had a fracture. They may have imbalance. They may a lot. The majority, up to sort of over 50% of patients after a hip fracture, remain dependent on others for mobility help and can easily fall and break something, and then it sort of drops down once they sort of get accustomed to everything, and strength is better and treatments start.
Perfect. And another question: if a patient with hyperparathyroidism has osteopenia, do you ever use FRAX for treatment decision, surgery versus conservative management versus bisphosphonates?
That's a very good question and probably worthy of its own talk. So the guidelines would suggest that in hyperparathyroidism, you proceed to surgery if there was osteoporosis rather than osteopenia or a fracture. However, there may be cases, for example, if you've done sequential DEXA scans, you see a rapidly decreasing bone mineral density, still within the osteopenic range, when you may say, actually, we need to jump in and do surgery early. Whether you do conservative management, so in some patients who are a bit older and frailer, then you can just sort of protect their bones with bisphosphonates or denosumab if an operation is not realistic. But if they're younger, I think we're moving to a sort of a world where we are quite aggressive in treating excess PTH. Given that you've got sort of limited duration of time, you can use some of these treatments, and sometimes the best treatment is just removing the offending parathyroid adenoma.
Perfect. One more question. Are intervertebral disc calcifications common?
Um, Not that common. No, I mean, you just basically want to look at the DEXA scan and then it looks fairly symmetrical all the way through. If there's a big mismatch between your spine and your total hip or femoral neck, then you can start thinking there may be some errors because your skeleton should be the same throughout, really. Um, so that's when if the one area is much worse than the other, then you could start to think that maybe there's some some consistent intervertebral disc calcification that's increasing your lumbar spine. But normally you'll find your lumbar spine is lower than your hips because it's got more trabecular bone, which is more vulnerable to disease.
Okay. One more question. In general, what do you consider a significant percentage change in bone mineral density above and beyond the limits of or the limitations of variability?
So that's a very good question. And if I did a DEXA scan on you 100 times today, the variation would be about 3 or 4%, unfortunately. So that's why we wait a while before repeating DEXA scans because you want to be sure that that change is not just a within the sort of variability of the machine. So 10% is about one T-score. So anything above 3 or 4% is definitely significant. Below that, it depends. If both all three areas are going in the same direction, then it's probably true. If one's going up and one's going down, or it's all by about 1% here and there, it could be some variation. It depends. Yeah, you need to sort of take the individual example.
Um, there's a question about steroids. Actually, I think that might be better saved for Dr. Bahari's talk later. And then the final question, and I won't keep you longer. If there's only right forearm osteoporosis in a hyperparathyroidism patient, would you recommend starting bone protective medication?
So here you can now in Frax Plus take hyperparathyroidism if you pay the €1 and go through to that, and it will adjust the risk, and that might give you an indication of what to do. But you can break that wrist. That patient can break that wrist if you don't do anything about it. So you need to have a think about whether you want to proceed to treatment, and you've got to sort of take a holistic viewpoint regarding other risk factors, their fitness for surgery, their prognosis overall in life, and things like that. But generally, if it's a young person with forearm osteoporosis and hyperparathyroid, then we would try to proceed to surgery.
Perfect. Well, thank you so much. I think that was all the questions for now. Thank you so much for coming and giving a talk for us. We're very grateful.
Yeah, pleasure. Thank you very much.
We've got a little bit of a break now until 11:30. So what I'll do, or you can sort of stretch your legs, and then I'll sort of come back online around 25 minutes past. Yeah, okay.
Okay, can you see my screen?
Not yet. Sorry.
Oh, yeah. Oh, okay, sorry. Let's try that again.
That's worked. Yeah, perfect.
Finally, apologies for that.
Yeah.
Thank you, Matthew, for inviting me and for the introduction. So I'm going to talk to you about alkaptonuria. And these are the messages that I'm hoping to get through to you in the next 42 minutes. So number one, AKU is a multi-system disease. AKU must be diagnosed by measurement of urinary homogenetic acid. Nitisinone is an approved disease-modifying therapy in AKU. Ochronotic spondyloarthropathy is common. Unfortunately, nitisinone doesn't reduce arthroplasty. And I think there's a bone disease theme today, and I've added some information about osteoporosis in AKU. It is common. Nitisinone and bisphosphonate can increase BMD, but we're not sure about fracture reduction. Teriparatide is safe and efficacious therapy if bisphosphonate doesn't work. This is the outline of the talk. Obviously, you can't talk about AKU without talking about the father of the human genetics, Archibald Garrott. I think there's a building is it in St. Mary Medical School? Or there may have been a ward on St. Bart's named after him. He described cases of alkaptonuria on his observation of urine from a family with alkaptonuria, 1899, and this was published in 1901. His Crunian lectures. But AKU date back. In fact, there was an Egyptian mummy called Harwa, and there was evidence of homogenetic acid on further chemical analysis and on the X-ray of the spine as well. So it's the earliest verified case of alkaptonuria. Obviously, audience is mainly metabolic medicine, so we all love metabolic pathways, and this is the tyrosine degradation pathway. So we start with phenylalanine, get converted to tyrosine, and then you have these HPPA, HPLA, these are intermediary, which then get converted to homogenetic acid. Now, in AKU, you have deficiency in homogenetic dioxygenase, and that lead to AKU. Homogenetic acid get converted to another compound, unstable compound called benzoquinone acetic acid. We're not entirely sure how the pigment or ochronosis in AKU form, but we think, through chemical bonding, it polymerizes. It has an affinity to connective tissues everywhere, in the heart, in the joints, in the spine, everywhere, and this is how ochronosis happen. And it's no surprise it's called black bone disease. So starting on the left top, you have these black spots in the eyes. So scleral ochronosis in an eye of AKU patient. This is an intraoperative picture of an elbow joint. You can see it's completely black, the joint. And these are two urine pots on the panel A, normal urine, and panel B, this is what we see, what happened when the urine is oxidized or exposed to sunshine. In terms of genetics, well, it maps the HDD gene, it maps to Chrome 3Q, which encode for the HGD enzyme. Mutation could be either compound heterozygous or homozygous. And we know there's more than 250 HGD variant. Not all of them leads to AKU. So you really have to get a biochemical diagnosis. You have to, so your first port of call, if you suspect somebody has AKU, you need to measure the homogenetic acid in the urine, not do genetic testing. There's a value for a pre-implantation diagnosis and counseling, but you can't diagnose it using genetics. In terms of prevalence, it's an ultra rare disease. So, anything from 1.25 million to 1 million. Slovakia, they did extensive works in the 70s. They have the highest prevalence of nearly 1 in 20,000. Similar high prevalence has been reported in Dominican Republic, Jordan, and India. Interestingly, in the 70s in Wales, they included AKU screening as part of their screening program, and over a 7-year period, they've recorded a frequency of 1 in 45,000. That's a lot. That's a lot. Nationally, I think you'd probably be aware of a pilot national screening program for neonatal genetic testing. Unfortunately, at this stage, AKU is not included, but I really do hope that down the line in the future, it can be included. And then hopefully once you identify mutation, then you can go to secondary testing by doing a urinary homogenetic acid to confirm the diagnosis. Mutation of HGD-MZI is it's available online and is kept by one of our collaborators in Slovakia, Dr. Zatkova. And as I've said, it's gold standard. It's really measurement of homogenetic acid concentration in the urine. I want to show you that AKU is multi-system disease, as you'd expect, because these homogenetic acid is circulating from birth. So it'll affect, it's a multi-system disease. So if you look at the eyes and the ears, you can see these ochronotic pigments here. It's very clear. If you look at the ears, this sort of bluish discoloration of the pinna, it's very clear. And across age, that it gets darker with age progression if the patient is not treated. There's also increased prevalence of cataract in AKU patient, but that gets worse when they are treated with nitisinone. This is a post-mortem photo of the costal cartilage, and you can see these pigmentation of the sternomastoid tendons over there, or obviously the sternal cartilage here. This is plaque pigmentation of the intervertebral discs. This is a photo of the aortic valve root, and you can see the ochronotic changes in the arch and also in the roots here. Aortic stenosis is a common problem. Again here, so panel A shows ochronosis in the carotid artery tree. It's mainly in the carotid sinus region here. This is from the abdominal aorta, and you can see the ochronotic pigmentation here. And this is a cross-section again from the aorta, panel C. You can see on the inside, the intima and the adventitia on the outside with relative sparing of the media. If you look at cardiac valve involvement, this panel on the left side, it goes up with age. So aortic stenosis is a really common problem. Our patient get a cardiac echo every year. There's also a coronary artery calcification. And actually, in some patients, if you have increased high lipoprotein A and coronary artery calcification from AKU, it does aortic stenosis does seem to accelerate quicker. We had one case. If you look at the spine, so this is a 48-year-old. Sorry, this patient is 18 years old. Beg your pardon. So this is a normal spine, wide disc space. This patient is 34. You can see the minimal narrowing of the disc space and some calcification. This patient is 46, so older. So the older you get, the more progressive changes you see, and even worse changes when this patient is 62 years old. In terms of joint replacement, well, it starts sort of mid-40s and get more common as they get older. Prostate stone, kidney stones. If you look at the This is just example of prostate bladder stones, but we do see prostate calcification even in younger patients as young as 25 or 30. Kidney stones is the same thing. Again, the older they are, the more common it is. So every patient who come to the National AKU Center, so I've demonstrated to you, it's a multi-system disease. So we try and capture all of that when the patient attend the center. So we have photographs of the ears and eyes, and we take history about kidney stones, prostate, all the rest of it. We scan them, scan the heart, looking for sclerosis or stenosis in the aortic valve. We also do bone scan to look for evidence of arthropathy. And we also ask them, give them a questionnaire for joint pain. We combine all of that in what we call the AKU Severity Score Index. This was developed by my mentor, Professor Ranganath, who established the center in Liverpool. So we score every patient every year, and we have to report the median of our cohort every year to the highly specialized services. In terms of management, historically, there hasn't been really a disease-modifying treatment for AKU, and it was all sort of be the palliative, physiotherapy, pain relief, joint replacement, supplement. There was some theories about vitamin C helping in reducing oxidative stress and all the rest of it. Low protein diet, none of it really worked. And we have this. So any idea what this plant called? I can't see the chat, so feel free to type in if you know what it is. I mean, judging by the shape, it's called, this plant is called the bottle brush plant. It's called the bottle brush plant. And this is where we get our nitisinone. Initially developed as weed killer, and then trialed for hereditary thalassemia type 1, and it was a life-saving treatment for these patients. A very, very interesting story. But that's nitisinone. And if we look again at the pathway, nitisinone blocks the HPDD enzyme. So you stop the accumulation. There's no more homogentic acid. But what you get is you block completely the degradation of tyrosine. So tyrosine, on the second day goes at least 10-fold higher, and that brings problem of its own, like mainly tyrosine keratopathy, which need to be managed. For now, we manage it by low protein diet. So all our patients, they have dietary assessment, detailed dietary assessment, and we put them on protein restriction. And sometimes they need to go on tyrosine-free amino acid supplementation for that. From our experience in the center, we have demonstrated that use of nitisinone, and we only use just a 2 milligram dose, ochronotic pigmentation can be reversed. And if you look, this is a patient, this is following just one patient from 2009, 2012, 2013. So the patient 2009, this is a baseline study that was done by Professor Ranganath. The National AKU Center was established in June 2012. That's when the patient started nitisinone. And you can see, compare between 2012 and 2018, their chronosis has become less and less. So there is an element of reversal there. it'd be unfair not to mention the research that is done in AKU. So in 2012, the National Center was established, and then around the same time, a European grant is being given to start the SONIA trial on suitability of nitisinone in alkaptonuria. So there was the SONIA 1 study, which basically just a dose response study to look at the reduction of urinary homogentic acid in AKU patient just over 4 weeks. And then there was the subclinical ochronosis features in AKU, basically just looking how early we can detect subclinical ochronosis. Patient had MRI scan, gait analysis, all the rest of it. And there was the SONIA 2 study, which basically looking at the safety and efficacy of a 10 milligram daily nitisinone. This was a European trial with center participating in Liverpool, in Paris, and Pishtani in Slovakia. And it was on the basis of the data from the SONIA 2 trial that actually the European Commission in October 2020 extended the indication of nitisinone to include AKU. So before it wasn't approved until October 2020, we prescribed nitisinone in the National AKU Center of license. There was no one else in the country prescribing nitisinone. And it now has become available across Europe, and the FDA in America has approved it as well. A bit about the National Center. It is called the Robert Gregory National AKU Center, and it was down to this remarkable man. He's a trade unionist from Liverpool who approached Professor Ranganath back in 2002 and said, I've got AKU. What can we do about it? They've established the AKU Society and, led the bid initially for the National Center and then to host the European trials that led to approval of nitisinone in AKU. So as I've said, our center started in 2012. It's an MDT assessment and treatment with a capacity of around 60. It's a one-stop service, and we use nitisinone. Initially, at the beginning, it was unlicensed, and we were asked to disseminate knowledge. Most of the work over the last sort of 10, 15 years related to AKU came out of Liverpool. And so our patient, they come to the center usually the first week of the month. We have 5 patients. They stay for 3-4 days. They'll go through all these assessments, so ophthalmology, dietetics, rheumatology, cardiology, pain clinic, all the rest of it, multiple investigation, radiological and all the rest of it, ECG, cardiology, gait analysis. And this is just a timetable of one patient on a baseline visit. And you can see it's really, it's full, it's very, very busy. And actually, we had patient complaining it's just too tiring going through all of that. But we do all of that in one go, and that's it. I know other regional centers or national centers, they do things in a different way, but that's the way that the service set up, and it works well for our patient. A follow-up visit works shorter, 2 days or 3 days. We work closely with the AKU Society. Our collaborative relationship is absolutely crucial for the success of the work that we do. And this is just a summary. The data is all, but just give you an idea of. Sorry, I've gone a bit. Yeah, the prevalence of some of the issues that we see, and I've mentioned before. We've compared data from the National Center and from the SONIA study, and actually you get you get better suppression of homogenetic acid, and likely so on the top panel, this is if you start 2 milligram of nitisinone around the age of sort of 36, 37. If without a treatment, you'll have features of worsening on the Y panel. On the Y-axis is the AKU SSI. That's the severity score. So you can see it's going up, but you can slow down. You can slow down the progression of the disease by around 25 years if you start 2 milligram around the age 36. If you start 10 milligram around the 23 years of age, well, by this mathematical extrapolation, you can delay it by 100 years. There you go. We won't live beyond 100 years. But that's all mathematical exploration. And the message I think I'm trying to say is, higher dose would be better. And we do encourage our patient to go on a higher dose if they can cope with the diet restriction. Okay, what about effect on the joints? Well, we know homogenetic acid does cause changes to the mechanics and the morphology of the cartilage. One become achronotic, it become fragile, and it does affect the metabolism. It becomes dehydrated, it becomes stiffer, it affects the cell matrix. So it's all HGA-induced damage. And if you look at how joints and spine are affected in our cohort, so the top panel, this reports the pain in the joints listed here. So you can see in most of our patients, the two most painful joints is the shoulder, both shoulders, both knees. I mean, you expect with the knees because they are weight bearing, but actually when you do PET scan, the most affected joints are the ankles, feet, and the shoulders. If you look at the spine, again, it's in terms of pain, patient will report lumbar, then cervical. It affects everywhere when you look at the PET scan imaging, mostly thoracic and lumbar. So why it's severe and premature? I don't think we know the exact answer. It could be HGA predisposing to generation of glycine radicals. Maybe there's a predisposition to osteoarthritis. We don't know exactly what's going on, but systemic homogenetic acid will probably has a lot to answer about this. So what about arthroplasty in these patients? Again, in our cohort. So if you look, so panel A shows you the number of patients who had replacement. So most patients have right or left knee. So we have nearly 25%. 20% shoulder replacement, and then you get the hip. So knee, hip, and shoulders. And this is the panel B just shows the number of years after the joint replacement. So 30% less than 5, 25% between 5 and 9. Many patients 15 to 19 years. We have few patients with over 25 years where they had the replacement surviving. If you look per patient, how many procedures, how many replacement they have? Well, we have one patient who had 10 joint replacement. He called himself the Iron Man. That's what he said. I'm not making this up. And then other patients 6 joints, 5 joints. So it does, and this is the yeah. So there is multiple joint replacement, unfortunately, and this is the panel D, shows the percentage of patients who are having multiple replacements. So there's quarter of the patient have 6 joint replacement. That's a lot. And unfortunately, the nitisinone doesn't, once you have a joint replacement, that's it. Nitisinone really doesn't change that. So you have to really start nitisinone early before you get a joint replacement. Now, in terms of osteoporosis in AKU, it's really underestimated. So bone loss, it's and fractures is underestimated. Some previous surveys, it was between 46 and 53% of fractures and osteopenia. Because of ochronosis of the lumbar spine, that in the same way, I'm sure, those of you who look after patient with osteoporosis, lumbar spine reading is always compromised because of the degenerative changes. In AKU patient is even worse because you have ochronosis, and even in younger patient having spinal ochronosis in their 30s, that's it. You can't rely on the lumbar spine. So that's an issue. And there isn't a published evidence what exactly you do with these patients. So we've looked at our a cohort of patients. And the first thing we did, we've compared the standard DEXA scan against the quantitative CT densitometry. So if you look, panel B compares the neck of femur BMD obtained from CT densitometry and from standard DEXA. They're very closely related. If you look at the lumbar spine data between the two modalities, the CT densitometry and the DEXA, it's all over the place. There's no correlation. If you look at total hip data, again, it's very, very closely correlated. If you compare data from the, I'm looking at the panel F, from the neck against CT densitometry, neck, femur, and lumbar spine is closely related. If you look total hip and lumbar spine is closely related. So there is a reliable relationship between the femoral neck and total hip data and the DEXA data. So if you happen to see one of my patients in your bone clinic, you can still do DEXA. You'll probably be fine looking at the hip data. We haven't done looking at the peripheral bones like the forearm, but non-vertebral DEXA we would still be useful. So there's data to back up. The DEXA, if lumbar spine, if it tells you, there's normal bone density in the spine, it really doesn't mean anything in AKU. And in terms, if you look at the fracture data, the patient with a higher vitamin D seems to have more fractures for some reason, when we're not sure. They are slightly heavier, and their ochronotic scores are higher. So they have worse disease. They have lower BMD, lower Z score. Okay. And this panel just compare what's the effect of adding anti-resorptive to nitisinone. Possibly it'll improve the bone density, possibly, or if you add nitisinone to anti-resorptive therapy. We haven't seen an effect in terms of fracture reduction. I'll skip that. Why this happened? Well, we know from the bone turnover markers that we've done, there's increased bone turnover in these patients. There's also focal osteoporosis. There's excessive osteoclastic activity. So on the basis of increased bone turnover, increased excessive osteoclastic activity, it makes sense to treat these patients with bisphosphonate, and that's what we do. That's our first line when we treat these patients. This is just comparing prevalence and incidence of fractures and osteopenia and osteoporosis, and it is higher in AKU patients. All these papers are available on PubMed for you. And we also trialed teriparatide in a couple of patients who had multiple fracture despite being on bisphosphonate for a long time. And they've stopped fracturing after we've gave them teriparatide. So that's another option potentially that can be tried. Okay, so in summary, it's osteoporosis in AKU. It's really common. Fractures are common. DEXA is not reliable. If you have access to QCT, that would be great. If you can't, then you lose the hip. You can use the hip data. Hip BMD will be useful. Total hip necrophrenia depth. There's increased bone resorption. And when you give anti-resorptive, the bone turnover goes down, BMD goes up, but we haven't seen a decrease in fracture. But I think it's more likely because of the numbers. We have very small numbers to prove that. So I conclude my talk by just these take-home messages. I hope I've demonstrated to you that AKU is a multi-system disease, need to be diagnosed by measurements of homogenetic acid. There is an approved disease-modifying treatment, which is nitisinone. It will require protein restriction until we find an alternative way of dealing with tyrosinemia. Arthroplasty is very common, and nitisinone doesn't reduce arthroplasty if the patient has one. And osteoporosis is common. You can use bisphosphonate. It does increase the BMD, but we're not sure about fracture reduction. If you are pushed to use a teriparatide, we have 2 cases that show that it can work. Brilliant. I'll stop here. Thank you, and happy to take any questions.
Perfect. Thank you, Dr. Kedra. That was a fantastic talk. And I hope people can put any questions in the in the chat. Can I clarify a couple of things with you before anyone else puts their thing? So, from what I understand, you're saying that the increased sort of or the lack of padding really from the cartilage is perhaps what causes this increase in fracture risk, and that's seen with people who are sort of increased weight, increased age, because they've had more years of sort of that weight going through I guess joint spaces. And you're expecting nitisinone to actually reduce that risk if you start it earlier on. Is that?
I don't. That's a really great question. Thank you, Matthew. I don't think we've got the evidence to support. You hope by reducing. Obviously, the offending agent here is the very high circulating homogenetic acid, and you'd think, okay, if this is playing a factor in focal osteoporosis and increased osteoclastic activity, increased bone turnover, you'd think by reducing that, you'll have less fracture risk, but we haven't seen that. But remember, it's so our current head count, the people who are actively on our book, we've seen over 100 patients, but the patients who are currently on it is around 70 patients. So it's hard. It's hard to by the randomized controlled trial benchmark to say this is how. But you'd hope that actually that's what gonna help. And nonetheless, I think hopefully with time, and that's brings me. It's difficult not to talk about this with AKU. We have a problem in picking up patients. These, and I'll have this anecdote for you. We had a patient local to us. He was in his 50s, a banker. He always had a problem with his left knee. He went for arthroscopy. It looked black. Orthopedic surgeon Googled it. Oh, this is AKU. Oh, I Google again. Oh, there's an AKU in Liverpool. So you should go to them. And so he was diagnosed with AKU, and then he went back to his parents and he was having a chat with them. He said, "Oh, well, I've been diagnosed with this. Do you know anything about it?" And they say, "Yeah, of course. When you were a baby, you had your nappies were blackened. They said you had AKU, but there's nothing we can do for you. So this is why we didn't even bring it to you. We didn't tell you anything." So our problem is, I think, what I'm trying to say with early diagnosis, that is the challenge for us. Currently, it's not being screened for. I understand why. There's strict criteria. You want treatment from sort of as soon after birth. That is not the case in pediatrics. There's concern about, I haven't alluded to, there's concern about the effect of nitisinone-induced tyrosinemia on cognition. So none of the pediatric metabolic specialists is keen on starting nitisinone. And even in our case, we wait until the patient is 18. There's lots of restriction with, I'm sure those of you who've been through the diabetes clinic, it's very challenging in younger cohort, trying to manage diet and lifestyle. And there's this it's very hard and challenging for everybody, for the patient, for the family, and for us. So we wait until 18. So we've got a long way to go. Sorry, that was a long-winded answer, but I think I agree with you. Hopefully, once we start picking up patients early, diagnose them early, maybe we will see the evidence. Actually, you can, if you start treatment early, you stop bone disease happening in the first place. This is how it should work, if it's all driven by homogentic acid.
Perfect, thank you. And there aren't any other questions. If you don't mind me asking another one.
No, please.
Have you started to see any signal towards reducing some of the coronary artery disease or the aortic stenosis from treating with nitisinone? I don't think I saw that.
Yeah, so that's another great question. Thank you, Matthew. Yes, so we have published data from the Center on Aortic Stenosis. So when the center was set up, obviously you have to exposure to radiation is a major issue, and we have to do it every year for 5 years. So coronary CT or calcium scoring wasn't on the cards, so I can't answer that question regarding. But in terms of aortic stenosis, yes, absolutely, it stabilized the disease, and especially in early stages. So we published on that. Yeah, we do have some patients who either didn't start treatment for whatever reason, or they are too old, and they have TAVI, and that seems to work beautifully for the patient, because the problem is when you when you try and operate on these patients, the cusps of the aortic valve fragment so easily because of the ochronosis in the tissue. And that can lead to emboli and things like that. But thankfully, we had quite a few patients. They had TAVI, and it was fine. So yes, it does stop disease progression. Yeah.
Perfect. Well, thank you so much. Thank you so much for coming and talking to us about it today.
Thank you for inviting me. Much appreciated. Thank you, and good luck with everything. Thank you.
Thank you. And I think we'll move on 1 minute early to Dr. Stokes. I've just made her a co-host, so let me just make sure I can pass you that. Hi, Dr. Stokes.
Hello.
I think you should be able to share your screen if
Yep, I'm just locating the button, and
that's okay.
this is new to me, but I found it.
Fantastic. And Dr. Stokes is a consultant endocrinologist, and she's going to talk to us today about the management of hyper and hypoparathyroidism in clinic. So welcome, and as I say again, thank you very much for coming and giving up your time.
No, thank you for the invite, Matthew. Can everyone see my screen?
Yeah.
Yeah. Fantastic. Okay, then I'll start. So I'm going to talk to you, as Matthew said, about the management of hyper and hypoparathyroidism in clinic. The aims of this session, so I've aimed it mainly at metabolic medicine trainees, but I know there's some endocrine and rheumatology trainees out there, and hopefully this will be useful for you too. I thought we'd start with a revision of calcium physiology. Then we talk about primary hyperparathyroidism. It's all based around a case. So hopefully make it a bit real world. We're going to talk about diagnosis, end organ damage and complications, and then management options, including the indications for surgery. And then we'll finish with hypoparathyroidism. So we'll talk about the etiology and diagnosis. And then we'll talk about the management, focusing on the new ESE guidelines, which are just out, which is very exciting for us all. I did have a look at the metabolic medicine curriculum, and I thought that these were the competencies. I hope I've got the right curriculum. These are the competencies we would be fulfilling. So causes of hypercalcemia and hypocalcemia and their treatments. Skills, we've got ability to manage hyper and hypocalcemia. I mean, obviously that's within parathyroid related disorders. And then behaviours, we will learn how to refer appropriate patients with hyperparathyroidism for surgery and manage patients with hypoparathyroidism appropriately to try to prevent long-term complications, e.g. nephrocalcinosis. And I think I'll explain why it's very, very difficult at the moment to fully prevent all of these complications. So to start with a revision of calcium and parathyroid physiology, can you see my cursor if I move that around?
Yeah, we can. Yeah,
you can. Lovely. So this picture here, this is supposed to represent the 4 parathyroid glands next to the thyroid, and they sort of sit at the 4 corners of the parathyroid gland, and they have expressed the calcium sensing receptor. And what that does is it senses the prevailing level of calcium in the blood. Hopefully, this is revision for everyone. When that drops below your body's happy set point, then the parathyroid glands increase their secretion of parathyroid hormone, or PTH. PTH has got 3 main actions. So you get increased osteoclast activity on bone, which releases calcium. You get increased reabsorption of calcium from the renal distal convoluted tubules and CDs. And again, that leads to increased calcium. And you also get increased action of 1-alpha hydroxylase within the kidney. Now, what alpha hydroxylase does is it takes your standard vitamin D, 25-hydroxyvitamin D, that comes either from diet or from the skin, and it activates it to form 125-hydroxyvitamin D, which then enhances calcium absorption in the gut. And all of these things lead to hypercalcemia. And as your calcium level goes up, you get a negative feedback effect on the parathyroid glands, and the level of PTH reduces a little bit. And that's how you maintain homeostasis. So we'll start, as I said, with hyperparathyroidism. And we've got a case, Mrs. BG, and this is based on a real world patient. who I saw in clinic a little while ago. So she's a 71-year-old lady. She was an urgent referral with an incidental finding of an adjusted calcium at 3.04 millimoles per litre. GP had done some blood tests to investigate hip pain. And I suppose when you're faced with this kind of referral, or when I'm faced with this kind of referral, the first thing that I'm thinking is this patient well or unwell? Is she symptomatic or asymptomatic? What's causing it? Could it be, has she got any other past medical history or medications? And what's her PTH level? Now, you would hope by the time they come to clinic that you would have a PTH, but I thought it's always good to start right at the very beginning. And when we're investigating hypercalcemia, the way that I think about it, and as with everything, it's classify or die. And as an endocrinologist, I think, is this PTH dependent or PTH independent? So PTH dependent causes, by far the most common cause is primary hyperparathyroidism. So that is an intrinsic overactivity of the parathyroid glands resulting in hypercalcemia. You've also got tertiary hyperparathyroidism, which is when you've got prolonged secondary hyperparathyroidism and the parathyroid glands become autonomous. Then we always have to think about FHH, and we'll talk about FHH in a little while. This is familial hypocalciuric hypercalcemia, and that mimics primary hyperparathyroidism. And then very rare in small print, you've got parathyroid carcinoma and ectopic PTH secretion from malignancy. Then in your PTH independent bracket, but by far the most common cause is going to be malignancy. But then you do see people who've got granulomatous disease, such as sarcoid or lymphoma, who get hypercalcemia. There's vitamin D intoxication, drugs, immobilization is on the list. And actually, if you've got a young patient who is immobile, it's not that uncommon for them to become hypercalcemic. And then you've got your endocrine causes, such as hypothyroidism and Addison's at the bottom. So Mrs. BG, was she symptomatic? So she had a bit of difficulty concentrating, a bit of polydipsia, polyuria, occasional constipation. She'd not fractured. She had no symptoms of kidney stones. In terms of her past medical history, she was hypertensive and had CKD stage 2. Excuse me. Medication, so she was taking maintenance dose cholecalciferol. This is your 25-hydroxyvitamin D, something for a hypertension, amlodipine. And we got her PTH and it was 35. So this lady has got primary hyperparathyroidism. And I suppose, she was fairly well. She's probably had it a long time and she was quite used to running a calcium of that level. So primary hyperparathyroidism, it is common. I'm sure you've all seen it. The incidence varies depending on your source. But the likelihood of you developing it increases with age, and you have a higher prevalence in women. It's associated with end organ damage. So the things we worry about are kidney stones and reduced bone mineral density. The majority of cases are caused by a single adenoma. So 80% one gland. You do also get 4-gland hyperplasia in about 10 to 15%. And then less commonly, you can get multiple adenomas. Again, the vast majority of these are sporadic. So there are risk factors, including radiation to the neck and lithium use. 10% will be genetic. So that might be, 50% seems high, but that's what's quoted. And that could be either syndromic or non-syndromic genetic etiology. So by syndromic, I'm talking about things like multiple endocrine neoplasia, where patients are, the primary hyperpara occurs as part of a wider syndrome where they're also prone to getting pancreatic neuroendocrine tumours, pituitary tumours, and the rest. Or there is things like isolated familial hyperparathyroidism, which would be your non-syndromic genetic causes. So differentiating FHH from primary hyperparathyroidism, this is important because patients with FHH, we generally think that their body is basically, what FHH is caused by a change in the body's set point for calcium. So the body wants the calcium to be higher. Majority of cases are caused by a mutation in the calcium sensing receptor. So it takes a higher calcium, prevailing calcium, to switch off your parathyroid hormone secretion. And we tend to think that these patients are asymptomatic of the hypercalcemia. It doesn't cause them problems with their bones. They don't get kidney stones. And if you give them a parathyroidectomy, it won't work because the remaining glands will work hard to maintain the hypercalcemia. So all patients with primary hyperparathyroidism, you should consider FHH in them. And there's lots of different ways that we consider FHH. So if a patient has had lifelong non-progressive hypercalcemia, then they are more likely to have FHH than somebody who has had a normal calcium that has suddenly shot up. That's not how FHH behaves. Some people look at the magnesium, it's significantly higher in FHH, but to be honest, that's not very helpful when you've got a patient in front of you because it's usually still within the normal range. If you've got a significantly elevated PTH, so certainly above 2 times the upper limit of normal, in the absence of other reasons to have an elevated PTH, then that suggests primary hyperparathyroidism rather than FHH. In FHH, patients will tend to have a PTH that is within the normal range, albeit at the upper end or only slightly elevated. And then urine calcium excretion, which is something as endocrinologists with an interest in parathyroid we talk about a lot. So I think what's important to say is there is significant overlap between patients who have got FHH type 1 and people who've got primary hyperparathyroidism and have a urinary calcium creatinine clearance ratio less than 0.01. So about 65% of FHH type 1 patients will fall into that bracket, but about 20% of primary hyperpara patients will also fall into that bracket. It's also important to know when you can use the calcium creatinine clearance ratio. It's only valid in patients who've got an EGFR above 60, who are vitamin D replete, who are not pregnant, who are not taking thiazides. So you need to make sure that you're doing the right test in the right person. And given the data that I've given you, so that you've also got to think about what is the likelihood of your patient having FHH before you do the test. So as I said, the positive predictive value is going to be affected by the disease prevalence. So if you've got an older patient, it's less likely to be FHH because primary hyperpara is more common. You do get primary hyperparathyroidism in young people. And I have to say, I think if you've got a young person who fits the bill for primary hyperparathyroidism, then that is still probably the most likely diagnosis. But their chance of having FHH or another genetic cause is going to be increased. And so I would always take the results of a urinary calcium creatinine clearance ratio with a pinch of salt. Yes, I think that's just important to say. I would not, obviously, if the ratio is less than 0.01, then that does suggest FHH, but it's not diagnostic. If it's above 0.01 or 0.02, depending what your cutoff is locally, again, it could still be FHH actually. So going back to our patient, her ratio was above 0.02. She also had a 24-hour urinary calcium, which was also high. And given the other factors, we thought it was sufficient to confirm her primary hyperparathyroidism. We gave her general advice. She was started on cinacalcet because her calcium was above 3, and she was screened for signs of end organ damage. So we did a DEXA scan looking at her bone density, and we investigated her for kidney stones. So the general advice that we give to patients with primary hyperparathyroidism, there is no need to restrict the dietary calcium intake, and that wouldn't be helpful anyway. We do ask that they try not to exceed the normal daily intake recommendation. Your vast majority of patients will not be doing that. I have had a patient who was eating, I'm not joking, 6 blocks of cheese, and I asked them to rein that in a little bit. But generally speaking, most people are within, are not having excessive amounts of calcium. We recommend that the 25-hydroxyvitamin D is maintained at between 50 and 75. Now, you can debate the exact level, but it is better that they are vitamin D sufficient, as this reduces parathyroid drive. So there's often a lot of confusion over this because people worry that if you give vitamin D supplementation, there's a risk of unmasking an even higher hypercalcemia. And I think that that's true. And generally speaking, I wouldn't advocate for giving replacement dose vitamin D. But if you've got somebody who's got a low vitamin D, it is fine to start them on maintenance dose. And NICE advocates 1,000 IU daily. And you might see their calcium move ever so slightly, but it's unlikely to be clinically significant. Very occasionally, we end up giving treatment dose vitamin D to people who are going to be having an urgent surgery for various reasons. And even then, and that tends to be in an inpatient setting, and even then we don't see their calcium move that much. So I wouldn't worry about this too much. We advise people to drink plenty to flush the calcium through the kidneys and reduce the risk of kidney stones, and we say at least 2 litres a day. Obviously, don't take calcium supplementation. Avoid thiazide diuretics, which promote calcium retention in the kidneys and can cause hypercalcemia. And then we generally say to monitor the calcium and PTH. You can say every 4 months, every 6 months. Or if you've got a patient on cinecalcet, you should check it 2 to 4 weeks after the dose change. Then vitamin D, once a patient has got sufficient vitamin D, you only really need to check it every 12 months. So just to talk a little bit about cinecalcet, because I've mentioned it, again, this is something you may all be familiar with. So cinecalcet is a calcium mimetic. It acts on the calcium sensing receptor within the parathyroids, and it basically makes the parathyroids think that the calcium is even higher than it actually is. So the level of PTH that they secrete is lower and the calcium reduces. And you see that the calcium normalizes in about 70 to 80% of primary hyperpara patients, and it will drop in nearly all of them. So it can be used as an alternative to surgery for patients who aren't suitable, who don't want it, or as a bridge to surgery in patients who are very symptomatic. And you are able to give it in patients who've got an adjusted calcium greater than or equal to 2.85, or asymptomatic patients who've got an adjusted calcium greater than or equal to 3 millimoles per litre. It can improve the symptoms of hypercalcemia, and a lot of our patients feel a little bit better on it. It has not been shown to have any proven benefit in terms of bone density or fracture risk, and there is no evidence that it reduces the risk of kidney stones. So its main benefit is calcium lowering and symptomatic. So to move on to the effects of primary hyperparathyroidism on bone. So all patients with primary hyperparathyroidism are recommended to get a DEXA scan by NICE. And what primary hyperparathyroidism shows or causes is predominantly cortical bone loss. So when you do a DEXA scan, depending on your centre, certainly here we will ask for them to do the distal third of the radius because that's where you will see it most. Whereas the cancellous bone is relatively spared. These patients have got an increased risk of fractures at all sites, so vertebral and peripheral, because they also get trabecular deterioration in the spine. It is fine to treat them with bisphosphonates. So I think certainly before COVID, what would happen is you'd have a patient with primary hyperparathyroidism, and they would either have their surgery, and that would be treatment for their bones, or they would be started on bisphosphonates. Now, here, and I know in a lot of centres, surgery is now delayed, and if so, in terms of the bisphosphonates, it's going to take at least 6 months to get much benefit from them. So if your surgery is delayed for more than 6 months and you've got a patient with osteoporosis, then it's best to start them on a bisphosphonate once it's diagnosed. Alendronate has been shown to improve the lumbar spine bone mineral density without affecting the calcium in primary hyperparathyroidism. And you can also use denosumab. I know a few centres use Zol as well. And you can use cinecalcet and alendronate in combination therapy. And I think the other thing to say about this is if you've got a patient who's got severe osteoporosis, I suppose the way I think about it is if you look at their bone density scan, you've got to think, is this likely to be all primary hyperparathyroidism, or have they got additional risk factors or additional causes for their osteoporosis? And if you've got somebody who's going for surgery with severe osteoporosis at all sites, I would be tempted to start them on bone strengthening treatment, even if the surgery is immediate, because I would suspect that the recovery in their bones post-parathyroidectomy is not going to be back to normal bone density, if that makes sense. So moving on to the renal effects of primary hyperpara. So 10 to 20% of patients have symptomatic kidney stones. More will have asymptomatic. You're at higher risk of this if you're young and male. And the 15 to 17% have renal dysfunction, which seems to remain stable over long periods of follow-up. So other effects, even mild primary hyperparathyroidism has been associated with depression, anxiety, fatigue, reduced quality of life. this isn't a sole indication for parathyroidectomy, because the results of randomized control trials examining the effect of parathyroidectomy on these neuropsychiatric effects are conflicting. So there is no proof that parathyroidectomy will improve them, and that's why this isn't a hard indication for surgery. Although in terms of the softer symptoms, rather than a psychiatric diagnosis, most patients report feeling better after their surgery. And it's a similar picture for cardiovascular effects. So primary hyperparathyroidism is associated with hypertension, so clinical coronary artery disease, valve calcification, and left ventricular hypertrophy. Looking at the data, it's difficult to unpick how much of that is an association rather than causation, and there's certainly no evidence of benefit with parathyroidectomy. So again, that is not a reason in itself to refer a patient for surgery. So going back to our patient, Mrs. BG, she had a DEXA scan and she was found to have osteoporosis in her forearm and also her lumbar spine, and then osteopenia in the hip. She had an ultrasound renal tract, which didn't show any nephrolithiasis. So she was put on cinacalcet 30 milligrams 3 times daily, but her adjusted calcium remained high. She was feeling unwell, she was nauseated, poor concentration and tired. And she decided to go for a parathyroidectomy. She was also started on a bisphosphonate for her bones. It's important to mention that cinacalcet in itself can cause nausea, and so sometimes it's worth adjusting the dose of cinacalcet to see if the patient tolerates a lower dose and feels better on a lower dose. So talking about parathyroidectomy, there is guidance for who should be referred for a parathyroidectomy and guidance as to who should not be referred for a parathyroidectomy. But as with everything, you need to use some nuanced judgment when you're applying this to your individual patient. So generally speaking, if you've got a patient who is under the age of 50, who has got symptoms consistent with hypercalcemia, who's got end organ disease, and that includes renal stones, fragility fractures, or osteoporosis, or who has an albumin-adjusted serum calcium that's 2.85 or above, those are relative indications for surgery. Each individual one is a relative indication for surgery. Now, you've got to balance that against the risk of surgery in your particular patient. And just to touch on the symptoms again, so in primary hyperparathyroidism, the symptoms of hypercalcemia are not necessarily proportional to the degree of hypercalcemia. It's also important to mention that all of these symptoms are very vague. And so you need to counsel all of your patients that you can't promise that they will get better, as they might not be down to the hypercalcemia. And that's why if the only indication for surgery is symptomatic improvement, I would always go in cautiously with that, because you can never guarantee that the symptoms are down to the hypercalcemia. So as I've said, you've got to use some nuanced judgment within the guidelines. When you're looking at the bones, the improvement in bone density and fracture risk reduction is seen 18 to 24 months post-operatively. So in our practice here, the typical waiting time for surgery from the day of their first appointment with endocrinology is about 12 months. And so you've got to think, okay, this patient in front of me, if I'm referring them for a parathyroidectomy, and the main reason for that is to improve their bone density or their fracture risk, then that's not going to happen for maybe 3 years. And that's important if you've got a very elderly patient. So if you have a patient or a very elderly, or you're thinking about their life expectancy, so you need to think, is a reduction in fracture risk in 3 years going to be meaningful in this patient? However, in an older patient who is very symptomatic, that might be more of an indication for surgery, because it's going to improve their quality of life. The other thing to sort of take into account when you're thinking of referring patients for surgery is if they've got parathyroid hyperplasia, so they haven't localized on imaging, or they're on lithium, or they have MEN1, they are more likely to need a bigger operation, so a 3.5 gland parathyroidectomy. And we usually have a higher threshold for referring those patients than we would somebody who is going to have a focused day case adenoma removal. I'm just going to check the chat, because I can see there's a few things there just to see if any is relevant. age-dependent reference. What I might do is come back to these right at the very end, if that's all right, and carry on, and then we'll come back to the questions. So non-surgical management options. So if the patient isn't going for surgery, then they will need ongoing surveillance of their calcium and PTH, because if they might be that the calcium becomes high enough for them to qualify for cinacalcet, for example. And we recommend that's done 6 monthly. In terms of bone density, you should review that every 1 to 2 years, or certainly review their fracture risk if they're not on treatment. And monitoring has been shown to be a safe option for about 8 to 10 years for patients with asymptomatic primary hyperparathyroidism, and lots of patients will remain asymptomatic and not develop any problems even beyond that. Obviously, if you've got somebody who's having surveillance, then you would want to consider imaging if they're getting symptoms of kidney stones or you suspect vertebral fractures, and you can give cinacalcet and bisphosphonates as required. So parathyroidectomy, the benefits, as we've touched on, I'll rush through. So improvement in bone density, reduction in fracture risk, reduction in renal stones and urinary calcium excretion, but there's been no proven improvement in renal function in these patients. There may be additional benefits on the cardiovascular, neurological and gastrointestinal systems, but there's a lack of evidence for that. Then risks of surgery, so vocal cord paralysis, hypoparathyroidism, especially if you're going for a 3.5 gland parathyroidectomy, neck hematoma or need for reoperation. And thankfully, the risks of most of these are very, very low. So it's better if your patient is operated on in a higher volume centre, so more than 40 cases a year, and they're going to have better outcomes if it's possible to do the surgery as minimally invasive rather than open neck. So before you do your surgery, you need to think about localization studies. So if you can localize your adenoma, you're more likely to be able to have a targeted surgery associated with lower complication rates, shorter operation, cheaper operation. And what we've done in Cambridge is we've looked at all of our data, and we found that in our centre, and it will vary from centre to centre depending on your imaging and your radiologist, but in our centre, we get the highest pickup rate on 4D CT. So that's what we do first line, and this is better for smaller lesions than sestamibi. And we scan from the base of the tongue to the mediastinum. Ultrasound can also be very good. You compare it with fine needle aspiration, but you get reduced sensitivity if patients have got thyroid disease or high BMI. Sestamibi, which you'll all be familiar with, has got about 90% sensitivity and specificity, but again can be masked by thyroid or submandibular gland activity. Then methionine PET CT can be really, really helpful, but it's not widely available. Might be more sensitive than sestamibi. And the sorts of pitfalls or things that make imaging more difficult to interpret are multifocal disease and ectopic adenomas, so in about 10 to 20% of first surgeries, the adenoma is maybe ectopic. And then if the patient is having a repeat surgery, then obviously it's more likely that they have an ectopic gland than if it's their first surgery. Right, going back to our patient, Mrs. BG. So she decided to go for a parathyroidectomy. She had a CT neck, ultrasound parathyroid, and a sestamibi scan, and she did not have an adenoma localized. So what our practice is here is we review the imaging, we discuss it with the surgeons, and the decision was made for her to have a bilateral neck exploration. We're a high volume centre, and our surgeons have really good results with a bilateral neck exploration. And what they do is depending on the imaging results, they will image either all 4 glands or the glands that they feel are most likely to be abnormal based on the imaging. They will have a look at those in direct sight and remove what they think needs to come out. And in this lady, she had her left inferior and right inferior glands removed because they were noted to be a little enlarged, and they were sent for pathology. So what do you do with these patients post-op? We monitor for hypocalcemia. They may get hypoparathyroidism, can be transient or permanent. They can also get hungry bone syndrome. If they've got a low PTH on their first post-op day, then that can predict temporary hypocalcemia and hypoparathyroidism. Hungry bone syndrome is associated with a normal high PTH, and it occurs 3 to 5 days post-op. Risk factors for that are patients who've had very high pre-op PTHs, or calciums, who've had low pre-op vitamin D, who have a large adenoma, evidence of bone disease on imaging, and an elevated ALP. It's also worth mentioning there's a higher risk of permanent hypoparathyroidism if it's a redo operation. Back to our patient. So she'd had, really quite a high PTH and calcium before her operation. So we did some enhanced monitoring and we gave her a bit of calcium in anticipation of hungry bone syndrome post-operatively. However, unfortunately, in her calcium and PTH remained high post-op, and she had to restart cinacalcet before discharge. So if we look at her histology, the normal, or we'll talk about histology first, so the normal average gland is about 5 by 3 by 1 millimeters and weighs about 50 milligrams. So they're very, very small. As I said before, an adenoma is most common. You can also get hyperplasia. So when histology is reported here, they will usually only say that a gland is an adenoma if they can see a thin rim of normal parathyroid tissue that's compressed around it. Otherwise, our histopathologists do not feel confident to say, yes, this is an adenoma or this is a hyperplastic gland. And that's important for counselling your patients post-operatively. Then moving on to parathyroid carcinoma, these are usually really big glands. They may be invasive, they may be adherent to adjacent structures, but to diagnose it, you need to have unequivocal invasion of the lymphovascular or perineural areas or into adjacent structures or distant metastases. So back to our patient. So she had 2 slightly enlarged glands removed, so her right inferior and left inferior. They were a bit bigger than usual. There was no thin rim of compressed parathyroid tissue seen on either of them. So in this lady, it's very difficult to say. I mean, it seems like the most likely thing in her was parathyroid hyperplasia. So the 2 biggest glands were taken out, but actually the other 2 glands that were left behind were also hyperplastic and resulting in increased PTH and hypercalcemia. So just to move on to genetic testing, who qualifies for formal genetic testing in primary hyperparathyroidism? So as with all genetic testing now, this is centralised through NHS England. You have to fulfil certain criteria in order to qualify for genetic testing. And then if you fulfill those criteria, you are tested for a panel of genes. So for primary hyperparathyroidism, it's the R151 gene panel. And the people who qualify are people who've got primary hyperparathyroidism specific genetics. So anyone under the age of 50. This is fairly new. It used to be lower than that. And actually, I'm sending off loads of people now for genetics and loads is coming back without a mutation. So I wouldn't be surprised if that changes again in the future. Or they need to have at least one of the following. So multiglandular disease or hyperplasia with relevant family history. So it's not enough for a patient just to have multiglandular disease or hyperplasia. They need to have the relevant family history. If somebody's got a parathyroid carcinoma or an atypical adenoma or a cystic adenoma, they can have genetics sent. If they've got ossifying fibromas of the maxilla or mandible, or if they've got a confirmed relevant family history, they can have genetics sent. Otherwise, it's patients who are suspected to have FHH, so somebody who's hypercalciuric, hypercalcemic and hypocalciuric. It's worth saying that variants of unknown significance VUS results are reasonably common, and what we tend to do here when we see that is our clinical genetics department will arrange familial testing to see if the variant is pathogenic. And again, just to muddy the water with the FHH patients, is we think about 25% of FHH patients are mutation negative. And so I have a cohort of patients who look and smell like FHH, but actually their genetics have come back negative. And I tend to keep them under follow-up for a little while just to show that they're not developing osteoporosis, everything is non-progressive. And then you can have a conversation with the patient about whether or not they stay in clinic and you do a calcium check every couple of years or what happens with them. So as I said, it's R151 is the gene panel, and you test for the 3 genes associated with FHH. and then you test for causes of familial hyperparathyroidism, and then in amongst that is some syndromic causes of hyperparathyroidism, including MEN. And so when you're counselling your patients, it's always really important to say that you are testing them for those conditions too. So longer term follow-up, patients are defined, felt to be cured if they're normocalcemic for a minimum of 6 months post-parathyroidectomy. If they then become hypercalcemic, you would classify it as a recurrence. You might want to think about genetic testing if you haven't done that preoperatively. And you may want to reassess their bone density with a repeat DEXA 12 to 18 months post-op. I only tend to do this if they had borderline osteoporosis pre-op and I've started them on treatment. If their osteoporosis is very severe, then I would just carry on with a full course of treatment. And I think lots of centres do this slightly differently. So always good to see what your centre does. The general advice is moving towards patients being recommended to have an annual calcium check, or certainly if they're symptomatic, they should have a calcium check, even if they're cured, because there is an increased risk of recurrence if you've had primary hyperparathyroidism. It's not recommended to do routine PTH measurement. All of these patients should maintain a sufficient vitamin D, and that's to reduce parathyroid drive. And if a patient is persistently hypercalcemic at 6 months after surgery, then you might want to think about a reoperation. And sometimes you might think about that even sooner than that. So recurrent hyperparathyroidism, as I said, the recommendation is generally not to do routine PTH checks post-op, other than, you know, your initial post-op period. A lot of patients will have an elevated PTH with a normal calcium after they've had successful surgery, and that is a condition that, if they fulfill certain criteria, we call normal calcemic hyperparathyroidism. And I could do a whole presentation on that, but in summary, we don't really know what to do with patients with normal calcemic hyperparathyroidism. There's no evidence of benefit of surgery, and it's often not diagnosed very well. So I would say only check the PTH if you want to know the PTH. Recurrent hyperparathyroidism is associated with patients who've got higher pre-op PTH levels, who are older and who have impaired renal function, and that fits with them having, you know, being more like having more pressure on the parathyroid glands. Again, a higher PTH is not consistently associated with an increased risk of recurrent primary hyperparathyroidism. And in that circumstance, you need to exclude secondary causes. So I'm going to move on to hypoparathyroidism now, and I'll take all questions at the end if that's okay. So hypoparathyroidism. It's a rare endocrine disorder, so it's about 6.4 to 37 per 100,000, in contrast to primary hyperparathyroidism. And the vast majority, 75%, is caused by anterior neck surgery. So it tends to be your patient who's had a total thyroidectomy for Graves, but a complicated operation, or someone who's had cancer neck surgery. And patients will often present with hypocalcemia symptoms, and that varies from a bit of paresthesia and muscle cramps to seizures and life-threatening laryngospasm. And you can also get neuropsychological manifestations and reduced quality of life in these patients. So just a quick revision of the physiology again. So you've got your parathyroid glands. They're not producing enough parathyroid hormone. So you have less calcitriol or 1,25-hydroxyvitamin D because you've got less 1-alpha hydroxylase activity. So you get less calcium absorption from the gut. You get decreased urinary calcium excretion before you treat them, and you also get decreased bone remodeling. So how to diagnose it? You've got a patient who's got a low calcium, be that albumin adjusted or low ionized calcium, and then a low or inappropriately normal PTH in the bottom of the normal range. Need to have that really on at least 2 occasions, and the guidance has changed recently to say that they need to have these changes for over 12 months post neck surgery. So parathyroid stunning is really quite common post neck surgery, and you will often see late recovery of the parathyroid glands. Up to 12 months certainly isn't uncommon. So you can also diagnose it if you've got a patient who's got severe hypocalcemia, and that's anyone who's got a calcium of less than 1.8 millimoles per litre, ECG signs, or severe symptoms such as carpal or pedal spasm, seizures and laryngospasm, and they need urgent IV calcium supplementation. And you've also got to check their magnesium before you diagnose hypoparathyroidism and correct it before making the diagnosis, as I'm sure you're all familiar with. So I've got a case, an 85-year-old man who was initially seen in rheumatology clinic because he had peripheral neuropathy and weak legs, slowness of thinking, poor memory, and a raised CK on statins. Past medical history of benign essential tremor, depression, AF, and allergic rhinitis. Medications are there. They checked his bloods in clinic and his adjusted calcium was 1.2 millimoles per litre, so he was advised to go to ED. In ED, he said he'd been fairly well. He said he'd had some hand cramps in recent months, so he'd clearly been tolerating this. He had an undetectable PTH. He had sufficient vitamin D, very low calcium, as I've said, slightly elevated phosphate. His ALP was mid-range, magnesium was normal, other bloods normal, and he had a slightly prolonged QTC. So he was started on IV calcium gluconate with cardiac monitoring, which was entirely appropriate. So when you get these patients, you need to work out what's causing their hypoparathyroidism, and the vast majority will have had neck surgery. And it's more likely that they will develop this if they have more extensive or complicated surgery. For example, if it's for cancer, if it's a reoperation, if they're obese and their neck is difficult to operate on. If they've got a very low parathyroid hormone level on the first post-surgical day, this is associated with hypoparathyroidism. So it used to be, before the latest guidance came out, it used to be that anybody we used to diagnose hypoparathyroidism if they had persistent hypoparathyroidism 6 months post-surgery. It's now up to 12 months post-surgery based on this data. So out of 8,832 thyroid surgeries, there was nearly 3,000 cases of post-operative hypoparathyroidism. And during the course of 6 months, about 74% of those recovered. But actually, another 81.3% recovered by the end of the 12 months. So they get an additional 7.4% recovery in the 6 to 12 month group. And I think the other thing to say is, if you've got a patient who's been diagnosed with post-op hypoparathyroidism, it's always worth really carefully looking at their biochemistry, because I've come across a lot of patients who've been chronically slightly over-replaced on activated vitamin D, and that then leads to a suppression of their PTH. But if you ease back and you let their calcium drop, or you ease back on their treatment, you can see that their parathyroid glands have recovered. So what about the small print? What about the people who haven't had surgery? So you can get transient hypoparathyroidism in certain circumstances, such as burns, acute illness, excess alcohol. You can get other causes of the parathyroid glands being destroyed. So granulomatous infiltration, radiation, malignant infiltration, mineral deposition, all of these things can destroy the parathyroid gland. Very, very rare. You can get an autoimmune condition which causes hypoparathyroidism, and that may or may not be associated with the AIRE mutation. And then there's genetic causes. So if you're suspecting that, you want to take a family history, look for syndromic features, and consider genetic testing. And in my practice, anyone who has an unexplained hypoparathyroidism gets genetic testing. So this is the R153 familial hypoparathyroidism testing, and this is for non-syndromic patients. And you can occasionally test normocalcemic patients. I haven't ever done that. Included in this panel is HDR. So this is often de novo, but patients may have associated deafness or renal abnormalities. APSED or APS1, where they will often have other autoimmune conditions. This is the autoimmune destruction of the parathyroid glands. You can get isolated primary hyperparathyroidism. You can get autosomal dominant hypocalcemia, which is basically the opposite of familial hypocalciuric hypercalcemia. And then there's rare neonatal conditions as well that are included in that testing. The other panel you might want to think about is the R293 Albright hereditary osteodystrophy panel. And for patients to have this thing, they need to have a clear clinical diagnosis of one of the conditions based on clinical, radiological, or biochemical assessment. So here, just got some pictures of the Albright hereditary osteodystrophy features. So short digits in metacarpals, especially the fourth and fifth, and you can see the knuckle dimple. And then they can be short, they can be obese, they can have a round face and some learning difficulties to a variable degree. So our patient, Mr. CT, so he had no syndromic features, no history of anything, no illness, didn't drink, no family history, couldn't find any old calcium levels, really went to town testing him and found nothing. Imaging was normal. I tested a parathyroid antibody, so I don't think you can test for this anymore. For a long time, you couldn't because of issues with the reagents, and I think I certainly can't even request the test now. Anyway, that was negative. And I have to say, a negative parathyroid antibody wouldn't necessarily mean that a patient doesn't have autoimmune cause. It's only if it's positive that it's even remotely useful. I also did genetic testing in him and didn't find a genetic cause. So his hypoparathyroidism was unexplained. So hypoparathyroidism, what complications might he face? So it's associated with an increased prevalence of renal stone disease, calcifications, and impaired renal function. And that tends to be as a consequence of the treatment that we give them. So we treat these patients with activated vitamin D and calcium supplementation, and without the action of PTH to allow some conservation of calcium at the kidneys, it all just leaks through the kidneys and causes these problems. These patients are also more likely to develop infections, neuropsychiatric disorders, muscle and bone pain. They may get proximal humerus fractures, they can get heart problems, strokes, cataracts, and they can get intracerebral calcifications. And it may be associated with increased all-cause mortality, although the data is not quite there to support that yet. So hypoparathyroidism is a really severe disease for a lot of patients, and it can really impact on their quality of life. So how do we manage it? So obviously you've got your emergency management of acute hypocalcemia, and then their long-term management. I've just realized I'm supposed to be finishing at 1, aren't I? I'll just go through my last few slides. Long-term management is a balance between maintaining an asymptomatic safe serum calcium concentration and avoiding complications. And if you normalize the calcium on conventional therapy, that often leads to hypercalciuria. The conventional treatment, as I said, activated calcium and calcium supplementation. You only really need to give the calcium supplements if their dietary calcium is insufficient. It can be given to act as a phosphate binder when it's taken with meals. There has been shown to be a proven benefit of maintaining the vitamin D above 50. And thiazide diuretics can sometimes help with hypercalciuria. I'm just going to skip over this. This is the new ESE guidelines for hypoparathyroidism, and it's a really good treatment algorithm, but you really have to get into it to work through it. And I think the take-home message is that now we have PTH replacement therapy on the treatment algorithm. So PTH replacement therapy. Hypoparathyroidism is the only endocrinopathy where we do not replace the missing hormone first line. And until recently, we didn't replace it at all. There is now a medication called Palipeg teriparatide, which is a replacement PTH licensed in hypoparathyroidism, but we do not yet have NICE approval. And the guidance is that this can be offered to anybody who is failing first-line therapy. And I'll skip over that quickly in the interest of time. So our patient remained under follow-up, never really found out what caused it. He thought it might be vaccine-related. And moving on to my summary. So primary hypoparathyroidism is common, often detected incidentally, and patients are usually well. You need to think about a genetic etiology in all of your patients because that's important for counselling and management. The only cure is parathyroidectomy. That's not necessary in all patients. The interpretation of imaging and histology is not always straightforward, so you need to make sure you have a firm biochemical diagnosis before proceeding. Then chronic hypoparathyroidism is rare, usually caused by neck surgery. Post-surgical patients may recover, and you need to keep an eye out for those who have a suppressed PTH caused by their treatment. It's worth checking genetics in any patient who doesn't have a clear cause. The first-line treatment is activated vitamin D and calcium, and iatrogenic harm is common. And recombinant PTH may soon be available as second-line treatment in selected cases. Thank you, and I'm sorry for running over.
No problem at all. Thank you so much and I also have to appreciate that I asked you to talk about a lot of different things in 45 minutes. So, if you don't mind, a couple of quick
No,
questions.
of course. Do you want to pick from the chat, or how do you want to do it?
Yeah, well,
Yeah,
I guess I'll start at the top. And
yeah, yeah, sure, yeah.
what are your views on having an age-dependent reference interval for PTH?
I think if you could get, I think if you could get, you could get the data. If the data was very, very good, then obviously it would be helpful. But I'm not sure that it's strictly necessary as things stand. I think we can, we can manage the PTH, the management of these conditions based on the PTH that we have, as long as you interpret it in light of the, in the context of age, is okay. So it would be great, but it's not strictly necessary, if that isn't too woolly an answer.
Does cinecalcit interfere with MIBG imaging?
No, I don't think so. Not as far as I'm aware.
Um, another quick question. What are the treatment options for managing hyperparathyroidism related symptomatic renal stone disease if someone's ineligible for surgery or if they are awaiting surgery?
So it's very, very difficult. I would say that I mean, it depends on how high their calcium is as well. I think certainly it's worth them being seen by the urologist or whoever manages kidney stones in your centre, to give them general advice, such as, they need to drink plenty, low salt diet. If they can get a stone, then the stone can be analysed, because it might be that they don't have a calcium stone. It could be they have oxalate stones as well. So I think that's worthwhile doing. It's not going to be appropriate to give them a thiazide. And then you've managed the stones as you would any other stones, say with lithotripsy or stenting.
Perfect.
And you could expedite the surgery as well. So that is an indication for a sooner surgery in our centre.
Perfect. Okay. Well, thank you so much. Probably all we've got time for. But yeah, thank you so much for giving your time and coming and speaking to us. It was fantastic talk.
No problem. Thank you for inviting me.
Thank you.
Thank you.
So yeah, so next up is Dr. Bahari, who I've just made a co-host. I need to ask you to unmute as well. So hopefully you'll be able to share your screen. So Dr. Bahari, are you struggling?
Yes, let me just. It's not letting me share, actually.
No, I can share for you. And you can just tell me when to click.
Do you want to share, Matt?
Yeah, I can do that.
Can't.
That's all right. Let me.
Thank you. You're probably going to need to do the
That's fine. I mean,
moving slide and animation for me as well.
That's okay. Just tell me when to click, and I'll do that. So, Dr. Bahari is a consultant endocrinologist, sort of locally where I work, and she's kindly agreed to give a talk on steroids and bone health. So yeah.
Yes, thank you very much, Matt. Yeah, thank you for this opportunity, and hello, everyone. So I decided to actually talk to you, focusing mainly on steroid and bone health. And I think most of you will probably agree with me that when it comes to starting patients on high-dose steroids, we tend to be quite good at thinking about PPI, gastric protection, but probably not so good at actually thinking about bone health. Maybe because we don't really know how to approach it or what to do about bone health in those patients. So hence, I'm hopeful that after this talk, we'll actually be a bit more engaged with the bone health in those patients going on high-dose steroids. So next slide, Matt. So my objectives are very simple. I want you to, at the end of the talk, to understand the effect of glucocorticoid on bone health, but mostly the distinctive effect it has on bone health as compared to other risk factors to the bone. And hopefully we'll go through some practical steps as how you would approach a patient, assess a patient, bone health, and also manage those patients who are at risk. Next one. So the next one is a Mentimeter. Would it work? It's probably not going to work, will it? It's my login.
I probably can't log in for you, unfortunately.
No. Okay. All right. That's fine. So it's a shame, actually. Okay, never mind. Okay. So the Mentimeter question would have been on thinking about the ways that steroid affects the bone. So if you go to the next slide, we can probably talk about it. So there's two main ways, if I was to kind of classify the effect of steroids on bones, is direct effect that steroid has on the bone cell itself, and also indirect effect of steroid as in the complication of glucosteroid that patients might be taking. So if you think about the direct effect, so high dose of steroid can affect your osteocytes, can actually increase apoptosis of the osteocyte. And your osteocytes, if you remember, maybe even from medical school, those are very important cells. Those are the mechanoreceptors in your bones. So they actually sense the loading effect on your bones and respond by signaling to your osteoblasts and your osteoclasts, so you have your bone remodeling. So those go down, the activity of the osteocyte goes down. Your osteoblast, there's increased apoptosis as well, and as you know, this is important for bone formation, so that's reduced. And the osteoclast also, the apoptosis go down, so you have more osteoclast, which promote bone resorption. So as combined effect, you have a decrease in your bone mass and a decrease in your bone strength. And then the indirect effects, so muscle wasting. So muscle wasting will lead to an offloading effect on your bones, which again is not good. That will increase bone resorption. And you have hypogonadism, which is can be associated with high-dose steroid taken over a long time. So if hypogonadism, low estrogen level is not good for the bones, as estrogens are very potent anti-resorptive, has anti-resorptive effect on your bones, and also low testosterone in man. Testosterone is anabolic in nature, so all that will interfere with your bone health. And we also have another mechanism, so which is a reduction in your gut absorption of calcium. And this can be quite a significant problem. So in one study where patients were started on high-dose steroids, at 2 weeks, there is about 30% reduction in your calcium absorption. And if you're not very good at replacing that calcium, what you would eventually end up is secondary hyperparathyroidism and increased bone resorption. Next one. Okay, so my Mentimeter here, I'm just trying to remember now, was meant to be on what are the sites most affected if you have, so what are the sites that are most affected if you have someone on high-dose steroids. So I'm giving you some options here. Go back, just stay there. And the one I wanted to pick is vertebral. So I think you all probably have been conscious of this, that the most patients going on glucocorticoid for a long time, they tend to present mostly with vertebral fracture. And the reason being, glucocorticoid preferentially affect trabecular bone. And your spine is very rich in trabecular bone. And this is quite specific for glucocorticoid effects on bones. If you think about, you've just had a talk on primary hyperpara. So if you think about primary hyperpara, it preferentially affects your cortical bone. So that's the reason why earlier in the disease, you get patients coming more with distal radius bone density lost or fractures. But here with glucocorticoid, the predilection is actually vertebra. So the spine fractures are quite common. Next one. Okay, So here, what I wanted to show you is what happened if you start high-dose steroid in men who normally have a stronger bone mass, who are also very healthy with very low risk of fracture. So how does that affect them if they start at a very good bone mass and low risk of having a fracture? So in this study here, we have men who were eugonadal in their 30s. They never had any previous steroid exposure, no illnesses, no medication that can interfere with the bones. And they were given 50 milligrams of prednisolone between 1 to 6 months. And if I can show you my pointer, I don't know whether that you can see that. Oh no, you won't be able to see it. So as you can see here, between 1 to 6 months, there is a significant drop in the BMD, especially at the lumbar spine. As we spoke about, this is actually the area mostly affected. And that's over a fairly short amount of time, 1 to 6 months. Now, you may ask yourself, what is 5% drop in BMD? Is that significant? So what I've got in a little box on the side is the average gain you would expect to see if you were actually to give zoledronate every year for 3 years in someone with osteoporosis. So you would eventually get to probably a mean gain of about 6.7% in the BMD. So losing 5% over 6 months is quite significant. Okay, so it does affect the bones quite a lot, even in patients starting with a high bone mass and at low risk of fracture. Next one. So the question is, what's the onset of the bone loss? So when does the bone loss happen once you start someone on steroids? Because not a lot of us will actually start steroids straight from the onset of, what I mean is start a bone protection straight on at the onset of actually starting steroid. So if you look at the graph on your left, which shows the risk of vertebral fracture across time in patients started at different doses of steroid. So the diamond shape one are the one at very low dose of steroid, less than 2.5 milligrams daily, and then the square one are 2.5 to 7.5, and the triangle one are more than 7.5. At the start, a year before, the risk of a vertebral fracture is quite low. But as you can see, from 0 to 3 months, there's a slight increase in the risk of vertebral fracture. But if you look at 3 to 6 months, the less than 2.5 milligrams of steroids stay pretty much the same throughout. But you can actually appreciate there's a more than doubling the effect on the risk of vertebral fracture in the 2.5 to 7.5 group, and probably more than a triple increase in the risk in the more than 7.5 group. And this is quite early on. We're talking about 3 to 6 months from starting steroid. And we're talking about not massive doses. Those are 2.5 to 7.5 milligrams of prednisolone. And if you look at the graph on the right in the square bit, what I want you to focus on is from the 0 to 6 months. Here in this study, they use a bit higher doses of steroid, so from less to 10 to above 20 milligram. And you can see here, so within 6 months, 3 to 6 months, there is on average between 2% up to 8% reduction in the bone density at the spine. So I think the takeaway message here is there is rapid onset of bone loss, okay? So within the first few months of starting steroids, and that coincides with a increased risk of fracture, especially at the spine. But what you can also appreciate, maybe if you look at the study beyond a year, beyond 12 months, so some of the data on the graph on the right, for example, that there's still an increased risk of fracture, but that risk slows down with time. So the increased risk, most of the increased risk happen early on, within the first few months of starting steroid, and that risk slow down after a year. Matt, next one. Okay, so what about doses of steroid and fracture risk? So in this study here, they look at various doses of steroid from 0 up to 25, and they plotted that against the relative risk of non-vertebral fracture here. And I just want to focus on 2 doses here, 5 milligrams of prednisolone to start with, so that's the red arrow. So 5 milligrams because I would say this is probably what we would think about a replacement dose of prednisolone, not really a suppressive dose. A lot of patients who've been on high dose of steroid for a long time, wean them down, and a lot of them probably stay on 5 milligrams maintenance dose. So what is the risk of fracture at that 5 milligram? As you can see here, the relative risk is 1.2. That's a 20% increase of non-vertebral fracture even at a dose of 5 milligram. What happened if you increase the dose? If you look at the second red arrow, the 20 milligram one, the risk goes up to 60%. So there's definitely a steroid dose response in terms of your fracture risk. Next one. Okay, so what happened when you stop steroids? Because that's also a very important question. So here, what I have on the x-axis, if I may explain, is a cumulative cortical steroid dose used in gram. Okay, so cumulative effect, cumulative dose from low dose up to a high dose of above 10 grams a day. And on the y-axis, you've got incident of non-vertebral fracture. If you just look at the lowest dose, less than 0.5 gram first, so of course the incident of non-vertebral fracture is increased. We know that. I've just shown you that. But when you stop the steroid, the dotted line is showing you what happened to that risk within the first year, and the second dotted line is showing you what happened to that risk in the second year. And as you can see here, so even at a small dose, the risk falls quite quickly within the first year and continue to fall maybe a bit more slower during the second year. And if you go at the highest dose, so extreme right on the x-axis, more than 10 grams, same thing apply. Even if the risk at the start is much higher than the smaller dose, once you stop the steroid, the risk falls, okay, within the year significantly and continue to fall within the second year as well. So the risk does go down. So maybe you should consider stopping steroid at that point, stopping at bone agent if you started that at the point of stopping steroid. Next one. All right, so I wanted to use a Mentimeter to do that, but maybe in your own sort of head, you can actually think about those cases. So I've got 3 classic cases here and 3 more, if you want, special cases. They all deal with starting steroids or on steroid and what you would do. So the first one is a patient with Crohn's starting 40 milligrams of steroid. And the aim is to taper over 4 to 6 weeks. So have a think whether this is someone where you would start a specific burn agent. What I mean by that, like alendronate or risedronate or zoledronate, would you going to start that in this patient? The second one is a younger woman, 34, with pulmonary sarcoidosis, starting on 20 of PrEP, so less dose, but for a longer time, so aiming to taper over 6 months. Is that someone that you would want to start a burn-specific agent? And the third one is an elderly gentleman starting on a much lower doses, 10 milligram of PrEP for PMR. Again, this is a longer time, 2 years, okay? So those are the 3, maybe more straightforward cases. And then the other 3 that I want you to think about is if you have a 45-year-old woman, type 1 diabetes with Addison's, starting on hydrocortisone. Those are the sort of traditional classic doses for replacement that you would use. If you have an asthmatic patient, 50-year-old, inhale steroid for a long time, like they normally do, and now suddenly starting a short course of 40 milligrams of prednisolone for 5 days for an exacerbation, let's say. And then finally, I want to think about Cushing's, because we talk about exogenous steroid. What about if it's endogenous steroid from Cushing disease, like a pituitary problem? And this is a young gentleman, 32, presenting with vertebral fracture. Just have a think what you would do in the situation. And later on, I will discuss after telling you a little bit, giving you a little bit more data. Next one, Matt. Okay, so that would have a Mentimeter. Never mind, let's skip that. All right, so just to kind of summarize what I've told you here, because I think these are the key concepts that I want you to understand. So once you start steroid, high-dose steroid, there's rapid bone loss. There's an increase in fracture risk very early on. And this increase in fracture risk and bone loss tend to happen at doses over 5 milligrams. So I showed you the data. And the duration is probably 3 months and over. That's when you actually see those bone loss happening. And there is decline of the cessation, so you can reassess the need for therapy for your bone protection if you started it at this point. So the key message here is really assess and intervene early before that bone loss and increase in fracture risk has happened. Next one. Okay, so now I'm going to move to how your approach to assessing your patient. So what you are aiming to do is a fracture risk assessment. So to do that, you want to actually ask the patient about certain risk factors. And I'm sure my colleague gave you a very nice talk earlier on about how to approach somebody with low bone mineral density and maybe talk about those risk factors for low bone mineral density. But these are some of the common ones that you should know about and you should actually ask your patient. And these are the risk factors that are most commonly covered in FRAX assessment as well. So you will need this information. Next one. So FRAX is really your friend here when it comes to making a decision whether you want to start any bone protection in your patient. What is it? It's a fracture risk calculator. It's validated. But the only thing I would caveat you against with using a FRAX, it's really underestimate the fracture risk in most patients. And there are a lot of things that FRAX does not take into account. For example, diabetes. I mean, if your patient's diabetes, it affects their bone. You know, it's a risk factor, but that you can't input that in FRAX. So what you could do, you could take another risk factor like rheumatoid arthritis, which is already there. Fall risk. Obviously, you're at risk of fracture, but that you can't actually account for that in FRAX as well. So I think it's always important to remember that FRAX underestimate the fracture risk. And that's because if you do your FRAX and you have a patient like borderline treatment threshold, I always err on the side of caution and would probably treat this patient. Next one. And you've probably seen that if you've used it, the FRAX calculator. So the most important thing is obviously to make sure that you have the correct country, UK, in there, because it does link up some guidelines to give you what you want to do next in terms of treatment thresholds. It's important to have the right country there. So you would normally fill in the risk factors, tick all the boxes that apply. When it comes to glucocorticoid, this is what you need to remember. So this is the paragraph that you do have on FRAX. So you would tick the box for glucocorticoid if your patient has been exposed to oral steroid. I've highlighted oral, it says oral, at a dose of more than 5 milligrams for over 3 months. Okay, so that's when you would actually tick the box. Now, what's really important and what people don't realize, it's also currently exposed or has been exposed. So if your patient has been exposed a year ago to more than 5 milligrams of prednisolone for over 3 months, this is a risk factor. So you would still tick that box. Okay, it doesn't mean current use of corticosteroid. Of course, that you would also tick the box, but also prior exposure will also constitute a risk factor there. The other thing is it's not just 5 milligrams over 3 months, it's a total steroid exposure that you want to assess. So if my patient was on 15 to 20 milligrams for 4 weeks, it's the same exposure as someone who's on 5 milligrams for 3 months. So if that's the case, so you do need to do a little bit of sort of maths there. And if it is a significant steroid exposure, then you would tick that box. I've also put in brackets there that it applies for parenteral steroid as well. And what I mean by that is other forms of steroids, such as mifepred, for example. So we do have patients in endocrinology, for example, with Graves' eye disease, who needs mifepred. They tend to get that every week for 6 weeks or more. So those patients, you would also tick that box there. So it's not just oral steroid. I think if you think about other potent steroid like mifepred, you would also apply and tick that box there to work out the risk. Next one. So if you have actually put all the risk factors in, including the femoral neck BMD, so if you have that, so sometimes you might be lucky your patient had a DEXA scan in the past or recently, you can put that in there. So what we like is the absolute BMD if you can, especially if you know the brand of the machine used, you can put that in there. At Imperial, it's the GE Luna, so then you can actually put the absolute BMD there and calculate the 10-year risk of fracture. Major osteoporotic fracture means anything of the spine, hip, wrist, and humerus, okay? And once you've got that risk there, the percentage risk, you actually click on the View Not guideline and you'll get that very nice little table at the bottom, which I'll put at the bottom, with where your patient lies, whether it's above treatment or below treatment threshold. Now, you only need one to actually start treatment. So if your patient is very high risk, they may be high on the major osteoporotic fracture and the hip, but if they're only high on the hip, for example, that's good enough for you to actually start intervention. Next one. Now, if you don't have a DEXA scan, you don't have a BMD to put in there, so FRAX will still give you an assessment of the risk of your patient and give you that output here. And you might be lucky, your patient might be very low risk in the green, you don't need to do anything, or you might still get the information you need because they're already in the red despite not having a BMD. But the issue is if they're in the amber, FRAX recommend you measuring the BMD, and that's when a DEXA scan might be quite useful. But what I don't want you to do is wait for a DEXA scan to actually start treatment. As I've shown you earlier on, the bone loss happened quite quickly, early few months. And depending on your center where you work, it may take months and months to get a DEXA scan, and you have to follow up, have a look at the results. By then, your patients might already have a fracture. So the practical thing to think about is your DEXA scan is not always needed. Okay, you can still have a sense from your FRAX where your patient lies in terms of a risk. And the other thing I want to caveat you against is, especially if you have a DEXA scan, sometimes patient might have a relatively preserved bone mineral density on the DEXA scan and still be at very high risk or already fractured. So don't be surprised if this is the case. And that's because glucocorticoid also affect not just the bone mineral density, which I've shown you before in the studies, but also the bone quality. And what I mean by that is the internal structure of your bones, the microarchitecture of the bone, really. And this is not captured on DEXA scan. So DEXA scan will just show you one aspect of how the bone is affected, but the bone quality is also affected in this condition. So don't get fooled, essentially, if your BMD is relatively well preserved, especially in young patients, that might be the case. Okay, next one. All right, so coming on to management. So the general principle, and I think you all know that, but I'm just going to go through in a little bit more detail. So your calcium and vitamin D. So we have good evidence now that your calcium and vitamin D optimization does mitigate against the effect of bone loss in steroid-induced osteoporosis or impact on the bone health. Okay, so it's important, very, very important. So with regards to calcium, what I would suggest and what we prefer is to actually get the calcium from your diet. So optimize your dietary calcium intake in the diet itself. You can use lots of calculators, calcium calculators out there. There's loads online. This is the one I put here, which is CalciTrack, which is an imperial-based calculator which we just come up with, essentially. So it's very new, but any calcium calculator you can use, where you put what's your target for your calcium intake for this patient. For this particular group of patients where we're starting high-dose glucocorticoid, I would aim for 1 gram of calcium a day. And then you can add your food and calculate how much they're actually taking and how to improve or optimize the calcium intake to up to 1 gram. So the use of calcium calculator, I think, is always quite useful to do it together with your patient. Vitamin D, of course, is very important, and you would normally get that through your supplements. Next one. Now, other things, again, these are things that you know, I'm sure you're aware of. So some modifiers, lifestyle modifiers, you want to encourage weight-bearing exercise in your patient, resistance exercise. If they're a smoker or alcohol intake more than 2 units per day, essentially, would be toxic to the bone. So you want to actually advise them on reducing those risk factors. And of course, I'm sure whoever starts a steroid, they always have that at the back of their mind. Is there an ongoing steroid need? Is there a way to actually use other steroid-sparing agent? And even thinking about whether in some cases you may get away without using oral steroids, maybe topical steroid for certain dermatology condition. Or maybe I've got some patients in clinic with inflammatory bowel disease where they use budesonide, which has very limited systemic absorption. So all these are potential options that I'm sure whoever's starting the steroid will be considering anyway. And of course, you want to use the smallest dose possible. What's really important, though, we should not forget that managing the underlying condition, because steroids is mostly used in inflammatory conditions where you have high-dose steroid over a long time. The inflammatory condition itself can really be detrimental to your bone health. So taking care of that can also help the bone. So there's obviously a need for the steroid to manage the inflammation or inflammatory condition, and that also would benefit the bones long term. So all that are very important. And as I said before, yes, you can consider stopping the bone agent when steroids stop. The other thing I haven't added here, but I'm just thinking about in terms of management, is have a low threshold for thinking about doing vertebral x-rays in your patient as well, especially if they're coming to you with a curved spine or loss of height. Vertebral fractures or can come, 70% of vertebral fractures are silent, okay, and they are only detected on incidental imaging, for example. So have a very low threshold of thinking to do x-rays if your patient have got loss of height or curved spine. Of course, if they've got pain, you would want to do it as well. It might change what you do or how you manage those patients in terms of their bone health. Next one. Oh, here we go. It was there. Next one. Yeah, next. Perfect. So we talk about the general management. So what about the bone agents themselves? So next one. Okay, so the guidelines that I tend to use is the National Osteoporosis Guideline in the UK. And they got a special section just on the glucocorticoid-induced osteoporosis. Having said that, there's lots of guidelines out there, lots of international guidelines, national guidelines as well, but this is the one we refer to the most for our patients. So here what I have in brackets are when to start bone protection in terms of a bone agent itself. And this is a strong recommendation. So even without your fracs, if someone has had a prior fragility fracture, it put them at a really high risk of actually having another fracture, especially going on steroid. I would even add to that, if they had a prior fragile fracture in the neck in the last 2 years, that's even more of a risk factor compared to someone who had a fragile fracture, let's say 10 years ago. I mean, it's kind of logical that the more recent it was, the higher the risk of them having another fragility fracture. Also, women above the age of 70, you would probably consider starting a bone agent. And then C and D are the one where I want you to focus on. So C are postmenopausal women and men above the age of 50, because that risk is already elevated. And if you're going to start glucocorticoid of more than 5 milligrams for over 3 months, or anything that is similar to that steroid exposure, so 20 milligrams over 4 weeks will be very similar, for example, that's when you have to think about your bone agent. And D talks about, again, postmenopausal women and men over the age of 50, but where your fracs is essentially suggesting that they are above treatment threshold and you want to start treatment. Next one. So here I've just summarized this. If you want to remember a lot of details, so this is what you have to remember. So postmenopausal women, men above the age of 50 with significant steroid exposure, as described there, or fracs, which is above treatment threshold, but special consideration for anyone with previous history of fragility fracture, especially if it's more recent, that really put them at a super high risk, essentially. Next one. Now, what agent do you start? Okay, so you normally would start with oral biphosphonate. So anything from alendronate to risedronate might be good, okay? In some patients, maybe risedronate might have a better option to alendronate, just because risedronate has got an on and off effect, which is much shorter, so shorter half-life if you want an alendronate. So in those patients where you are thinking that they may not need steroid for that long, maybe a few months, maybe 6 months, so you want to cover them with a burn agent, and at the end of the 6 months you want to stop, risedronate might be better just because of a shorter half-life, doesn't stay in the system for that long. But other things that you might be considering as well, intravenous zoledronate can be used as well. Denosumab, I will really caution against that, because it's not one of those medications you want to give 1 or 2 doses and then stop. You might actually cause more harm. So I would really think hard about using denosumab. And as I said before, calcium, vitamin D in all patients, really important. Next one. When to stop, I think we covered that already. So the guidelines, strong recommendation as well. So you can withdraw your bone protection therapy at the time where you're stopping the steroid. However, what they say is do a risk assessment, because that's where your DEXA scan can be quite useful as well. Because if your patient's already starting with very low bone density, let's say they have osteoporosis on the DEXA scan, you would probably want to continue for longer, not just when the steroids stop. But if they had pretty much good bone density, then you would probably stop at the same time as the glucocorticoid. Next one. Right, so so the guidelines focus a lot about postmenopausal women, as you've noticed, and men above the age of 50. So what about your younger population? Okay, so younger premenopausal women or younger men under the age of 40 especially. So what I would say here, you have to be very cautious when it comes to prescribing biphosphonate, especially to women of childbearing age. And that's mainly because biphosphonate, even oral biphosphonate, they can stay in the system. They can stay in your bones for years and years and years, even after stopping taking them. And there's no human data per se, but there are some animal studies where they found that it can cross the placenta, number one, and it can actually affect fetal bone growth. But that's animal studies, okay? And I have a patient who has been on biphosphonate and given birth and absolutely healthy, perfectly normal babies. But the caution is there. And personal practice, I would try to avoid it. If I have a younger woman, I would try to avoid oral biphosphonate. So what do you do in those young patients? Still use your FRAX. You might find on FRAX, it's been validated for the age of 40 to 99. So if your patient is 30, it will not accept it. So you just put the age as 40, okay? Which is not so much of a problem. Obviously, if you have a patient who's 18 or 19, it might be more of an issue. But normally you just put 40 in the age box so that you can actually work out a risk, fracture risk assessment for them. So if it's a male and the FRAX tells you that they are above treatment threshold, I won't be that anxious about starting biphosphonate. But as I say, if it's a female, I will try to avoid if I can. What can you do? And that's probably the time where you have to talk to your friendly rheumatologist, endocrinologist about what to do next. In my practice, if we're really worried about a young woman of reproductive age or who is planning pregnancy in the future, and we really need to do something about their bones, we'll be thinking about like anabolic, like teriparatide, for example, which is very short acting, very short half-life essentially. Can be stopped for pregnancy. And the other thing we can think of, if it is a young woman and let's say they've got like a nasty condition, inflammatory condition, I'm thinking about like probably like Crohn's or colitis, where they've lost a lot of weight, nutrition might be a problem, and they've lost their periods, for example, HRT might actually be a good option there as well. Okay, next one. Right, so now I told you about the special cases. So we're going to visit the sort of literature around those. So next one, Matt. So what do you do about patients who are on replacement dose of steroids? So I'm thinking about the Addison's patient. I'm thinking about your pituitary patient who's lost their cortisol axis, but also those patients who'll be on high-dose steroid for a long, long, long time, having adrenal suppression, not quite got better, and still having a small dose of 5 milligrams of prednisolone for a long time. Okay, so what about them? Are we worried about their bone health? What does the data show? Next one. So I don't want you to go to read the studies, okay, that's more for a reason, but what I want you to appreciate, these are a summary of studies in patients with Addison's on hydrocortisone as a replacement. And I've kind of summarized on the right what the studies show. And it's quite alarming if you look at these results, they're all kind of consistently saying there's a decrease in your BMD, there is an increase in vertebral fracture, and that's at low dose, replacement dose we're talking about. Okay, next one. So yeah, so overall, that's what the data is showing us. But these studies are all observational. They're cross-sectional studies. They're not RCTs. And if you dig a little bit deeper, you'll find that the doses that has been used as replacement in those studies are supraphysiological. So they are like more closer to 30 milligrams of hydrocortisone, which is closer to sort of 5 to 7.5 milligrams of prednisolone. And we know from previous data that I showed you, these doses can harm the bones. But these are not really replacement doses. They are what we call supraphysiological. They are over-replacement doses. And the other thing that also come across is there's that overzealous use of a sick day rule. So we're all very obviously cautious about crisis, adrenal crisis, and very quickly double the dose of steroids in our patient. And in clinic, I remember there's quite a few patients actually, they will double their dose for very minor things, like having a fight with their partner, for example, feeling very stressed, and they'll just double their dose. So you don't want that, because that extra unnecessary exposure to higher dose of steroid for a long time. So at Imperial itself, what we found is if you really want to have a very sort of what we call a replacement dose, you can actually go down to even 3 milligrams of prednisolone in some patients. So 3 to 4 is what we would consider a good replacement dose for most patients where the adrenal or pituitary is not working very well. Some patients can even do with 2 milligrams of prednisolone. So I really believe that despite the data that I show you, that in those who are not over-treated with steroids, so really tight maintenance dose, we won't really see a lot of bone impairment, okay? And I know that Prof. Mirand and Dr. Chaudhry they are trying to publish the data there, so it'll be quite interesting. They looked into this area. It'll be quite interesting to see what they find. And then all patient calcium, vitamin D, weight-bearing exercise, so just the general management rules. Next one. Okay, so that's the other group. So inhaled steroids. So we all see lots of asthma and COPD patients on, years and years of inhaled steroid. What does the data show there? So if you focus on the left table first, so this was a systematic meta-analysis essentially of fracture risk with long-term inhaled steroid in asthmatic. The overall outcome was there's no increased risk. Okay, so you can see the sort of diamond shape. So overall was right in the middle, so no increased risk. But then if you look at the studies, there's one study which looks extremely very positive, and one study extremely very negative in terms of impact on the bones. So there's a lot of heterogeneity in the data. Okay, so that's something to bear in mind. And then on the right, there was another systematic review, and this one had got some RCTs as well. And that one was a more recent one, 2021, where they showed no effect on the bones with inhaled steroid. This is asthmatic patient, but they did find a signal in terms of the higher doses of inhaled steroid if the patients are exposed to higher doses, there's an increased risk of osteoporosis and fracture. Next one, Matt. So this paper there, this table is just summarizing a nice review of several studies in the literature looking into that. There's lots of studies actually looking to inhaled steroid and asthma, but no studies actually confirmed that it harms or disconfirmed essentially that it is actually completely safe. But this is a nice summary which basically just say there's conflicting evidence. We don't know whether it's caused harm, and we don't know to what extent it caused harm. And what this review reported, which I think is quite interesting, is they combine a lot of studies together and basically make the conclusion that if your mean daily dose of inhaled glucosteroid is less than 800 milligram, it's less likely that you'll have a detrimental effect on the bones, which I find quite interesting. 800 microgram, I was just speaking to a GP this morning, I think that's quite a high dose, daily dose of inhaled steroid to be taken daily. Next one. What about us, COPD patient? COPD patient obviously a bit more different because having COPD itself confers an increased risk to your bone health by smoking. This patient are mostly underweight, malnourished sometimes, and obviously they might have recurrent infection requiring oral steroids, short courses of oral steroids. So over time, all this have an impact on their bones. So here, just a summary of all studies here. Again, very mixed findings. Okay, so some studies so increased risk, other studies no increase. Some studies even like positive results in terms of effect of steroid on bone health, which I doubt. But overall, very mixed finding. And I think it's very difficult, as I say, to disentangle the effect of purely the inhaled steroid on the bones to all the other factors that we know can impact bone in a COPD patient. So it's very difficult. But again, the management plan will be the same. You risk assess your patient with your FRAX, okay? Use a DEXA scan might be quite helpful, especially if exposed to steroid for a number of years. Then a DEXA scan might show you the results of that. But the main thing I want to say here, you have to individualize the treatment. It's very difficult to give general rules or guidelines here, but individualize the treatment to the patient's own fracture risk. So they may need burn agent, but optimized calcium and vitamin D is really important as well. Next one. And the last special case is endogenous steroids, so Cushing syndrome, essentially. So the MRI I've got here is actually from my own patient. So he was a 32-year-old Cushing patient who presented to us about 2 to 3 years ago, and that was his spine. Okay, so that was his MRI, and that was at that presentation. I'm sure you don't need a radiologist here to show you where the fractures are. So multiple vertebral fracture. He was in pain. He couldn't work for months. He couldn't walk properly. He couldn't come to clinic appointments. He was miserable, okay, very miserable. And the facts are, patients with Cushing syndrome, up to 50% of them, so half of them, will have a vertebral fracture. And they may present as a first symptom, symptoms presenting to you in clinic might just be a vertebral fracture. So it's very, very common. And we know that the fracture risk is highest maybe in the 2 to 3 years prior to diagnosis. And that's because that's the time it takes for most patients to be diagnosed. And during that time, they already had exposure to high dose cortisol and therefore had bone impairment all along before presentation. But what we also know that once actually you've sorted the problem, you've done a surgery, pituitary surgery, adrenal surgery, and they are in remission, your bone will recover. But what people are not so much aware of is that recovery can be slow. It can take years to fully recover from the effect of endogenous cortisol. What that means is your patient is remaining at high fracture risk for a few years before eventually the bones get completely back to what it was at baseline. Okay, so that's something we have to bear in mind. Next one. So I thought I could share with you some work that we've done here at Imperial, looking at how physician, here endocrinologist, engages with bone health assessment and management in patients with Cushing's. Okay, so this is a paper that's just been accepted 2 weeks ago, actually, in clinical endocrinology. But I just want to paint that picture to you, like what our engagement, do we think enough about bone health actually in patients with high cortisol or starting on high dose of steroids. So this was just a review of 79 patients that we had at Imperial, presented with endogenous Cushing's. And what we found here was only 43% of that cohort, high risk of fractures cohort, had vitamin D level checked. We found that only 39% of that population received any bone health management. We're talking about either it was calcium or vitamin D or a burn agent. Okay, so only 39%, so very low, received anything. 18% had fractures within 2 years of diagnosis, which is a little bit lower than what you would expect, but that's because we were not actively looking for fractures. And as I said, 70% of vertebral fractures are silent. So unless you think about it, you look for it, you're not going to find it. As expected, we did find that the bone mineral density improved in all patients after remission. But very interestingly, when we look at follow-up of those patients, so in the 2 to 3 years after remission, 46% had fractures. Okay, so despite remission, in the years following remission, people were still fracturing, essentially. So I'm sure this project was actually looking just at Cushing syndrome, but I'm sure it probably reflects what physician engagement with bone health overall probably is when we actually start patients on high-dose steroids. Okay, next one. So what I would suggest for endogenous Cushing, so just the same, the calcium, vitamin D, your FRAX assess your patient, DEXA scan if needed, and then just individualized approach whether your patient needs bone agent or not. There's, again, no guidelines, no rules to really tell you what you need to do. Just logical way of managing bone health, really. And the most important thing here is obviously achieving remission quickly. Okay, some patient you may not be able to diagnose what the problem is, what the lesion is. There may be delay in surgery. Those are the patient at high risk of fracture. You probably need to intervene while waiting for remission to happen. And as I said before, there's no targeted guidelines. The use of bone-specific agent like bisphosphonate in Cushing syndrome is debatable. Some papers say there's no added benefit apart from just remission from the condition. And some papers say, well, if you use bisphosphonate, it can accelerate bone recovery. So worth considering for the right patient. Okay. Yeah, next one. Now, coming back to the steroid use cases. So again, I would have done a Mentimeter here, but do you want to go next slide, Matt? And next slide, one more slide. Okay, so you had some time to think about what you would do. So what I can do now is just tell you what I would do, okay, and kind of the rationale as why I would start treatment or not start treatment. So if you have your 58-year-old man or female, sorry, with Crohn's starting 40 milligrams of pred, the risk factors is she's postmenopausal. She's starting a high dose of pred, even if it's just for 4 to 6 weeks. The steroid exposure is significant. The guidelines are very clear. You should be starting that lady on a bone agent like alendronate or risedronate. Okay, so hope you all agree with me. Next one. So this is a young woman with pulmonary sarcoid starting at 20 milligrams of pred for probably over 6 months. And here, yes, steroid exposure is significant, but she's young. So I want to know whether she's completed her family, for example. If not, then I would try to avoid, okay? Because obviously young, reproductive age. So what else can I do? She's got sarcoid, so I have to be really careful. I don't want to give her vitamin D here. She's probably got a lot of activation of her own vitamin D. So that's where your own individualized treatment is very important. I would still try to optimize dietary calcium. I think that's okay. You could aim for like 700 to 800 milligrams of calcium a day, which is what we should all be having anyway. And then try to build up her bones in other ways, exercise. If she hasn't got periods, HRT might be a useful tool to use here. Next one. Yeah, so this is quite straightforward. I hope you all agree. Elderly man, yeah, high risk of fracture already due to the age, significant steroid exposure. I would definitely start a bone protection here. Next one. Your Addison's patient, well, I wouldn't necessarily start anything. Yeah, type 1 diabetes is a risk factor, so I'll probably just do a Frax. If obviously she's above treatment, that's different, I would start, but I wouldn't start based on the fact that she's just starting hydrocortisone at replacement dose. Next one. Your asthma patient. So again, I wouldn't necessarily start bone protection here based on the information that I have, because a short course of prednisolone, and as I told you, the data is very mixed whether inhaled steroid has a really significant impact on the bones or not. But she's got some risk factors. She's 50, she's probably perimenopause, who knows? So I would still probably want to do a Frax and maybe a DEXA scan to guide me more, but I wouldn't automatically start her on any bone protection. And the last one. The last one is my Cushing patient. Well, again, with him, when we Fraxed him, it was low, it was below treatment threshold. But you will all agree, if you have a 32-year-old with multiple vertebral fractures, can barely walk, you want to do something. You want to do something active. And in his case, we did treat him, and we chose to give him teriparatide, and he did really well. So sometimes it's just your judgment, really, that has to apply. There's no guidelines per se. Next one. I think we're nearing the end. Okay, so just kind of recapping and summarizing what I told you, I think just remember steroid effect on bones is quite rapid bone loss, and that coincides with increased fracture risk quite early on within the first 3 to 6 months. So you do need to act early. You can't just say, let me just wait 6 months down the line and then actually start bone protection. You want to do it at the same time. Your Frax is your friend, as I said, so risk assess your patient. If there's only 2 things that I want you to remember is the dose threshold, so 5 milligrams of prednisolone over 3 months, or the equivalent in postmenopausal women or men above the age of 50, you would consider starting. And obviously, if the Frax is actually above treatment threshold, you would also want to start. Next. For inhaled steroid, topical steroid, I didn't give you the data for topical steroid, but it's all the same. Endogenous, we don't really have good data or guidelines per se, so you have to individualize your assessment and then your management as well. Remember, caution with bisphosphonate in the female. Yeah, lifestyle, vitamin D, calcium in all patients. Okay, so that's always should be the case. And you start steroid, you should always start calcium, vitamin D. Calcium from the diet is the best. The only exception is your sarcoid patient. And then your burn agent can often stop when you stop the steroid. Next one, I think that's the end, guys. So thank you very much for listening. I'm very happy to take any questions.
Thank you very much, Dr. Harry. That was fantastic. I think I've got a couple of questions in the chat. Do I have any questions in the chat? Yeah, sorry. Do you have any guidelines for oncologists now they have patients on high dose steroids for IO toxicity?
For IO toxicity, what's IO?
Yeah,
sorry, my ignorance.
Sorry, me too. So you're not alone. Immunotherapy toxicity.
You mean like dexamethasone and so on? Is that, I suppose, that what you mean? Okay, so I think the guidelines in terms of it's a high dose steroid, you would do the same thing. The guidelines apply to all specialty in terms of whatever you're using the steroid for. If it is dexamethasone, it's super potent. Absolutely, you just need to assess conversion of dexamethasone to your prednisolone. But to me, anyone on dexamethasone will have very high level of exposure to steroid, and you would want to start burn protection early. Whether there's any contraindication with biphosphonate to other chemotherapy, I'm not sure. It depends. Not with immunotherapy, as far as I'm aware, but I think it should be fine to use biphosphonate. I mean, you guys use it a lot in oncology anyway for bones lesions and so calcium and so on.
I think there's a comment that not sure that the oncologists are fully aware of the importance of that. But I guess really across the board, especially in patients with COPD or asthma who repeatedly come in to hospital on sort of multiple doses of steroids, and no one really ever thinks about bone health.
No.
I can't say I've ever seen anyone or even thought about it myself if ever. So someone else has asked in young patients, 20s to 30s, where FRAX isn't really valid, but you think clinically high risk. What is your reasoning or rationale for which agents to use in addition to calcium or vitamin D, in addition to calcium and vitamin D?
I think it depends on the risk. For example, if I had a young patient coming with fractures already, fragility fractures, that put them at a super high risk. Okay, and then obviously you've got the DEXA scan with the Z scores that we're going to tell you as well whether they've got low bone mineral density. So there's a few patients, for example, with pregnancy and lactation osteoporosis, so they fractured multiple vertebrae during pregnancy. So those are patients of very high risk. If they want to actually contemplate end of pregnancy, I'm never going to give them biphosphonate. So then you think about what the best agent to give them, and that will be anabolic. So that will be the exception to the rule where I'll use anabolic in those patients. And again, this young one is very tricky. You have to talk to a specialist to get a little bit of a feel of what's the best for them. And if they have lost a period, as I said, that's a good thing for you to actually intervene then and give them HRT, and that will actually help the bone health as well.
Okay, well, thank you so much. I think that's all the questions. Thank you so much for coming and agreeing to give a to give a talk. Super helpful. Thank you.
You.